and I'll do this twice. If a person is not breathing, I'm going to just do what we call a head tilt chin lift. And that's, you guys will see that here shortly. To try to clear the airway, I'll make an adjustment. They're not breathing, I'll do it one more time. If they don't breathe, I'll mark them as dead, which is be with a, or moored, which will be with a black, because it's color coded, band, and I'll move on. Okay, let's say I address the airway, they're breathing, and I see signs of bleeding. I move on, so here's the puzzle piece, guys. I move from the airway obstruction because are they breathing or not? Okay, so I don't need to do anything there. Now I want to go here. I'm looking for bleeding, blood, whether it's distension or in the stomach, whether I see blood out on the floor. I'm going to check for bleeding by what we call a cap refill. We're going to go over that, or capillary refill. That's how fast the blood returns. Okay. Now, if there's no bleeding, let's say if there is bleeding, right? I'm going to address that issue real quick. So I have my 4x4 gauze and some bandage real quickly, because remember, I'm not treating. This is the first phase. I'm going to 4x4 in there, I'm going to wrap it, and I'm going to keep moving. Time is of essence, guys. This, between here and here, in determining where I'm going to put them as immediate, delayed, or more. I have 30 seconds to complete that. I'm going to show you guys how to do that real fast. 30 seconds. You'll be watching some videos later today, and you'll see the firemen approaching the scene. Same thing that you guys will be doing. Okay? So, airway is clear. I've addressed the bleeding and shock. We're going to learn how to determine that, whether a person's in shock or not. First priority of medical operations: open airway, control excessive bleeding, and treat for shock. Regardless of what you guys may see in the field, whether it's an amputation, because guess what? You can see that. Returning or responding as surgery doing a big event, right? Whether it's an amputation or impaled object, okay? What we're going to be addressing only, only thing we're going to be addressing is airway obstruction, bleeding, and shock. Okay? When you approach a survivor, be sure that the person can see you. If a person is lying this way, feet this way, head this way, and I'm approaching from the top, hi, my name is Derek. First thing they're going to do is, when someone calls your name, hey Derek, and they're on my back behind me on the right side, I turn and look. I want to turn my head. I don't know if there's an injury or not. Okay, so if possible, where the environment permits, approach where they can see you. Start talking when you're at a point visible to them. So as much as possible, you can prevent additional movement. Okay. Again, what's the first thing I'm going to do before I approach any scene? What's the first thing I need to do? Before that,
make sure you're safe.
Assess, make sure that you're safe. Scene safety. What's the other thing? They go together. PPE, personal protective equipment. The scene is safe. I have my personal protective equipment on. I am now approaching my victim, introducing myself. Everything, first thing. Scene safety, you're safe. Scene safety, your safety, PPE. before you do anything. We work as team members here as well. At minimum, 2 people. At minimum. Don't do anything by yourself, guys. Okay? Be sure that the survivor can see you, identify yourself. My name is Derek, I'm with San Jose CERT. Is it okay if I help you? Again, respect cultural differences. If someone tells you not to touch a family member of theirs, do not. Don't. You can try to explain when they're bleeding, but guys, I'm sorry. It's not up to us to make that decision or that choice. Yes, sir.
But we can't provide them the tools to do it themselves. But we can't provide them the tools to do it themselves.
Sure, yeah, you say, here's a Band-Aid, here's some gauze, wrap your, yeah, you definitely do that. Yeah, you definitely do that, yes. No medications though.
So if someone is unconscious, they can like service with somebody else's
Can you speak up a little louder?
like let's say somebody's unconscious, can we give them treatment if somebody from their family gives consent?
Well, if someone from the family, well, that's another legal thing. It depends on if this person has legal rights, right? If this person is a, what's the word for that? A person has legal authority to make medical decisions, like an advance directive, something like that. That person could, but if not, as far as our treatment on an unconscious person, implied consent. Nick, do you want to address that aspect of it?
Sure, this can get a little bit sticky, but basically, if the person is unconscious and if the person for any reason is unable to make decisions for themselves, like they're drunk, they're not oriented, they really don't know where they are, what time it is, who the people around them are, those kinds of things. That's when implied consent comes into play, and you absolutely can treat them. On the other hand, if you've got a family member who's being combative, for your personal safety, the wise choice might be to back off. That's a real tough position to be put in, especially if the person needs major medical attention right away. But you need to back off and get law enforcement involved right away, or something like that. But fundamentally, the only people who really can refuse treatment are competent adults, right? Competent meaning they're awake, they're alert, they're oriented. Then you absolutely must respect their decision to decline to be treated.
Her question was if just say you have a person here that's unconscious, they can't respond, and a family member wants you to treat
Family member, if that person is unconscious, that family member has no right to tell you you can't treat them. You have every right to treat them. I'm just saying that if it's gonna be a conflict, you may have to back off, get law enforcement involved. And that would be the right thing to do. If this person needs medical attention right away and the family's objecting to it, just get law enforcement involved right away. Don't put yourself in jeopardy by getting into a fight with the family about it. But you have the right to treat that unconscious person. Children whose parents aren't present, you absolutely have the right, they really should treat them. Because nobody but their parents has the right to say that you can't. We run into that all the time. You get babysitters out with kids and they get hurt. The kids go in the hospital because parents aren't there to decline.
Thank you. Okay, so that was a good in-depth discussion on respecting cultural differences and what you can and can't do. Okay? So when we're talking about a head tilt chin lift, I'm not going to go into this too much in detail. This is just a diagram you guys can look at, anatomical positioning of your part of your respiratory system. You have your nasal cavity, which is the nose, you have the glottis, back of the throat, the pharynx, larynx, trach, and bronchial. So, how many people in here have swallowed their tongue before? Or you know somebody that has swallowed their tongue? Or heard of it?
What?
Heard.
See, yeah, I knew it was going to be wrong. Some people said, what?
No.
And then my two guys up front said, I know somebody that swallowed their tongue.
It's attached to the city map.
Thank you. It's not possible. Yes, sir. It's not possible. You hear that. So basically what happens is, it can happen in a drunk person or an unconscious person. It relaxes and falls to the back of the throat. You see right here, here's the tongue with an open airway. Here's the tongue with an obstructed airway. See here, and you see here. See the differences there? That's closed, and that's open. So, yeah, exactly. So the down, back, and down. And so what happens is when you relax, when you're drunk or inebriated and unconscious, that relaxes and you choke, you asphyxiate. So basically with the head tilt chin lift, and we have, Colin, we have the video on that, right?
We do, yeah.
So you guys will be actually seeing the stuff in the video. You'll see the proper way we do the head tilt chin lift. Simply place one head on the forehead and on the chin. And once I tilt the head back, it lifts the tongue away. Okay?
I have a question.
Yes, sir.
Would you ever be able to use a neck brace to open the airway, or is that something that's?
No, we won't be doing
Okay.
that. No, we won't be doing that. No manufactured equipment for stuff like that for us guys, as CERT members, okay? Some other things. So guys, the stuff that I'm talking to you guys about is all strictly related to CERT. None of it has to do with my previous disciplines, because that especially for me when I'm doing the medical, I like to keep that together. I don't like to mix it up, because even though I can do a trait in the field, I know how to do that. I've been trained to do that. I've been trained to do sutures. If I'm wearing my green, which is my shirt, I'm not doing any of that. I'm not doing any of that because we're not trained that shirt. This is a FEMA program. So the stuff that we talk about in here medically as certs, guys, I don't care what you do as a civilian. You can do whatever you want as a civilian. But as cert members, as far as the medical response, we're doing only what's being presented on the screen. Guys got it? For medical, we're only responding to what we're gonna be doing on screen. So, for example, if I saw something out in the field, I'm gonna do only what we're doing here. But once I wanted to start going advanced, if I chose to take on that responsibility, I'm taking my certificate off. I'm not telling you guys to do that. I'm saying stick strictly to what we learned in cert. And that's the only way these gonna be protected through the Good Samaritan and the DSW, okay? Okay, here's an example of the head tilt chin lift, where you're putting the two fingers under the chin, simply lifting the chin up and tilting the head back, and you guys can see as it's lifting away. Head tilt chin lift. So the first thing I do when I walk and I see this person that's having a problem breathing, this is the first thing I'm gonna do. I'm gonna address their airway. I'm gonna try to open the airway. I do that 2 times. Remember these numbers, because this is gonna be important for your skills there. Okay? Here we go. Call it a video. Is it here or have you got it? Next one.
If you find someone unconscious, you first need to check that the area is safe, and then check the response of the person, the casualty. This animation assumes that you, the rescuer, have already carried out these stages. Now you are ready for the next stage of the rescue, checking the airway. To tilt the head and open the airway, press down on the forehead with one hand and lift the chin with the index and middle fingers of the other hand. If you think the spine may be injured, take extra care when lifting the chin. The airway is now open.
Okay, you guys see that? Real easy. Okay. If I'm checking for the airway, so what I really wanna pay attention to is, I wanna get a good visual, right? I wanna be able to see the rise and chest of, rise and fall of the chest. Okay, I wanna be able to possibly listen for air expelling, for possible obstructions. You might get things like gurgling, you know. So you want a good visual of the rise and fall in the chest. You can look for it in the shoulders, you can look for it in the chest, and listen, right? And if you're close and you're listening like that, you're listening at the same time watching the fall, rise and fall of the chest, okay? So that's addressing the airway. The first thing is I wanna address the airway. The ways that I'm addressing the airway is looking and listening, watching for the rise and fall of the chest. If there's no open airway, I'm gonna do what type of maneuver? What is it called? A head tilt chin lift. How many times will I do that to try to open it?
Twice.
Oh yeah, you guys just passed. Moving on. Here we go. So we covered the airway, guys. That was the first one. We're already on to the second. So are you guys gonna do a lot for that? For the airway? What's the most you're gonna do for the airway? And again, how many times? Important, guys, because you're gonna have to take this out to the field with you. So I told you it was in chronological order. Airway, we've addressed that. Now we're going to bleeding. And the reason why we address the bleeding next is because bleeding can lead to what?
Shock.
Shock. Okay, now let's connect that. 3 different types of bleeding, guys. We have what we call arterial bleeding, which is bleeding from the arteries. Okay, you have venous bleeding, bleeding from the veins. So this is a general way of kind of looking at this. These two, arterial and venous, they sort of look alike. And you'll see what we're talking about. And there are 3 different stages. One is worse than the other, is worse than the other. Yes, sir.
Where are all your main arteries at?
Your arteries are deep. I'm gonna go there right now. Your arteries are deep, and that's good question. That's gonna align with the type of blood that you see, okay? So, I'm gonna go with so the description of these is arterial bleeding, bleeding from the arteries, spurts. Venous bleeding, bleeding from the veins, it flows. Capillary, bleeding from capillary, it oozes. Now watch this, when you see the picture, you'll start getting some ideas. So when we look at this arterial bleed, and it's from the wrist, what do you think, what could possibly have happened here? Exactly. They hit what? Exactly. They hit an artery. And look, see how that comes out? But look at the vein. What do you see the difference between these two? Exactly. Now it might not just jump out like that. It depends on how close that is to the heart, whether it's actually spurting out, right? But it's definitely going to be a good amount of blood, and you'll definitely know. For the vein, it's typically a lot, but it really is more flowing like this. What would this be a good example of? There it is. You fall, road rash, strawberries, I think they call them, right? Strawberries. That's what a cap is more like.
Is that goes into the tree part after that happens?
Oh, okay. You have one?
Capillary one?
Exactly. So it's more to the outer layer, okay? So guys, watch this. Capillary, dig up more, what's your name, young man?
Alvaro?
Who?
Alvaro?
Alvaro?
Yeah.
Alvaro. So watch this, the 3 levels. Capillary, the outer part of the skin. Venous, the second layer. Arterial, the first layer, is the deepest, right? So that's why you get the blood flow at those levels. Control bleeding. We have 3 methods for control bleeding. The first one is direct pressure. Okay? Simply put the 4x4 directly over the cut, the injury, okay? Elevation, bringing the arm up, and pressure points, okay? We have this femoral, popliteal, we're gonna go over those right now. Okay? So you have a brachial pressure point. Guys, let's right quick, let's just try to find that on our bodies here. Bring your arms up to 90 degrees, okay? Go to your elbow, move up, and it's right between like your bicep and your arm. You'll feel it. If you touch it, you'll feel it beating. The pulse. Guys, feel that? You can't use all of those. Use your index and your middle finger, guys, and press in there, and you'll find it. You don't want to use your thumb because your thumb has a pulse. So work on that. It's like between the bicep and the tricep, okay? Huh? No, I'm just showing you guys your brachial points here. Your pressure points. The other one, these are great for when you start talking about tourniquets, right? Femoral pressure point, okay, right in the pubic area. You can maybe just kind of envision that right now, but later on you can go right in there. Again, taking those first 2 fingers, okay? And then the popliteal, which is, guys can do this, is right behind the knee, using those fingertips. Touch it hard enough, press in there, you will feel the pulse behind that too. These are the 3 pressure points. How many pressure points are there? 3. Okay, so this is for upper limbs, lower limbs.
And like for those, like, those where you, like, that's where you put the tourniquet, correct? If it's like goes lower that spot, or just
So, let's say if I had when you apply the tourniquet, which is gonna be another area that we're gonna talk specifically about, you wanna tighten it up to where you no longer can feel a pulse in that area, right? So I wanna go above the injury. Exactly, 1 to 2 inches above the injury. We're gonna go on that separately, okay? So when we're talking about that in particular, 1 to 2 inches above the injury at these pressure points, okay? So all the time back in. Tourniquet, is the video included, Colin?
Sorry?
Is the tourniquet video included in this?
Yeah, we have a couple of slides here that talk more about tourniquet. Go ahead. And the whole idea is here, just one more, is that tourniquets can save lives. And they're associated by people like us putting them on people who are injured with a 6-fold decrease in mortality. So that's a good thing, which means that you, as a rescuer, can go up there and apply a tourniquet and have a 6-fold decrease in mortality. You're actually saving lives by using a tourniquet. And you know, some people are worried about losing a limb when you apply a tourniquet, but if you get that person through advanced medical care within 2 to 4 hours,
probably little chance of that happening. So next slide, I'd like to talk about, and one more click, is this pilot over in Iraq had a tourniquet in place for 16 hours. This is the world's record as far as I know. This is not going to happen for you, but you won't have anybody with a tourniquet on that long. But the limb was salvaged, and that pilot is back flying now. He had minimal neurological problems, nerve damage from the tourniquet being on that long, but this just shows that tourniquets are safe. Yes?
Hey, what's the normal amount of time that a limb can be detached and then reattached onto a person?
I don't know with an amputation what the time is for reattaching the limb. I know there is a time, but I don't know what the time is.
Okay, I was just wondering. I just like noticed that we were talking about the record.
Sometimes it also depends on the severity of it. And guess what? In addition to that, it also depends on the person's physical condition prior to the injury. So there's a few things.
Okay, that's cool. I was wondering.
Here's our video.
So guys, this is an example of a tourniquet. Very good one. We'll watch this video here.
This is a tourniquet. In this video, I'm going to show you how to apply a tourniquet. It is important to know when to use a tourniquet. The bleeding has to be severe and not stop with primary pressure. The tourniquet that I'll demonstrate has a windlass and a clip. There are 4 major components to this type of tourniquet: the band, the windlass, the clip, and the strap. These are the steps for a tourniquet with a windlass. Slide the injured extremity through the loop of the self-adhering band. Pull the free running end of the self-adhering band tight and securely fasten it back on itself. Twist the windlass until the bleeding stops. Lock the windlass in place with the clip. Ensure the distal pulse is no longer palpable. Write the time on the strap.
We had a couple of things there. One is, notice he didn't say anything about elevation or pressure points. Don't waste a lot of time trying those. They don't help much, and it's probably going to come out of this person. So direct pressure is your first choice. The other thing with a tourniquet, if you need to use a tourniquet to control bleeding, it's going to hurt. It's going to hurt a lot. And the person may want you to take it off or loosen it up, but don't. Once you put it on, it stays on. Only a medical person should take it off. Just be prepared for the person saying, man, that really, really hurts. Yes?
How long should somebody go on for?
Well, you saw that the record was 16 hours, as short as possible. When I worked as a paramedic a long time ago, I reported to Tony, a long time ago. If we put a tourniquet on, that meant they were probably going to lose that limb. So science has made a whole lot of progress since then in terms of being able to preserve function. Well, I'll tell you a quick story about the Gilroy Garlic Festival shooting a couple of years ago. There was a fellow who had a tourniquet on his arm, and we're going to talk about, we've already talked a bit about triage, and if somebody is bleeding and it's not controllable, they're a top priority. Get them to the hospital as fast as possible. Once this guy had the tourniquet on, he was no longer bleeding, and he actually became low priority to go to the hospital. And a bunch of people went before him, and this even kind of confounded the paramedics who picked him up, because they said, please take this guy to Stanford. And it was rush hour traffic, so they were saying it's going to take, hour and a half to go from Gilroy all the way to Stanford, and this guy has a tourniquet on. Because I think when we all started out, we always felt like, if you put a tourniquet on, it's a big, big emergency. But the reality is, medicine is so good now at preserving the function of the limb that it's no longer a big emergency. And actually had the time to take up my crown all the way to Stanford. So it's really interesting where all this has come in the last just in recent years, and they keep coming up with more and more ways to deal with it. But fundamentally, for all these kinds of things, your priority is to get this person into a higher level of medical care as soon as possible. There's, none of this should cause you to say, oh, let's all take our time now. You still want to keep things moving as quickly as possible, because if you need a tourniquet, it's a big deal, and they are very painful. Yeah.
So if it's past 16 hours, they lose the limb.
Sorry?
If it's past 16 hours, like you said.
Probably wouldn't lose the limb these days, but they might lose some function. Some of the nerves might die, and the nerves, they're getting better, getting nerves to regrow and so forth. But the more time goes by, the longer it's going to take to recover, and it might not feel as good. Just like everything else, the longer it goes on, the longer it's going to take to heal, and the greater the chances it might not feel good. And there's some point at which they're going to lose it, but apparently that's more than 16 hours.
And with all the stuff that Nick is saying, that's the reason why the use of the tourniquet, they apply it to the curriculum, they take it out, they say use it, they say don't use it. It just goes back and forth. But if you do, follow these procedures, okay?
Only use it if you can't control with direct pressure. By the way, something about that, direct pressure can mean, well, like if you get somebody bleeding up in here, and we've had firefighter injuries up here, you can't really get a tourniquet that high up to stop that. And so direct pressure in that case, do whatever you need to do. Put dressings on there, put a bandage on it to hold in place, and then stand on it if you need to get enough pressure to stop that bleeding. Because the person will die if you don't stop that bleeding. So if you have to stand on it to get enough pressure in there, stand on it. Lots and lots of pressure.
Any more questions on that, guys? Guys, just real quick, how many different types of bleeds will they possibly be? Okay, yes.
All my things are true, but if you do it, it could go that's not true. That's not true.
That you can put coffee
Yeah.
on what?
Like when you cook yourself, like you know how they put that,
Like in there, you stop
like that salt that foams up?
Oh, coffee I've never heard of. I've never heard that.
You might burn them.
You talking about the coffee grains? You're not talking about the coffee. You're talking about the grains, right? To my medical training, I've never heard of it.
Don't put anything other than a bandage to stop bleeding.
For us, as sir, again, I'm dressing what we do as sir. I've never heard that one before. Super glue, which was originally made for as a medical use, that's another story. I'm not gonna tell you to go out and use super glue.
Don't.
Wait, what? I had no idea that's what
Yes.
you
Yes, but typically what we're gonna be cleaning with is water. Yeah, running water through there. Dude, definitely, alcohol does not go inside of a wound. That's what cleans and on the outside. We don't even use peroxide, guys. I'm gonna say this again. Outside of the CERT curriculum, I don't mind asking a question and answering if I can. But outside of what we're teaching here today for medical response, for what you guys are being trained for, don't do anything other than what you're being taught.
Yeah, let's be real clear. The only way you should ever clean a wound, as CERT, is with a gentle stream of clean water. It just has to be clean. It doesn't have to be sterile. It has to be clean. A gentle stream, that's it. If you can't get it clean that way, it's gotta go to a doctor. And the only thing you should be putting on it is a sterile, ideally sterile bandage with a dressing hold in place.
So if you had like a bottle of water that you were drinking from, could you?
Yeah. Well, we use, on fires, we use drinking water all the time. In fact, take a pen, poke a little tiny hole in the top of in the cap of a drinking water bottle, makes a great gentle spray to clean out wounds. Do it all the time.
Yeah.
But by the way,
Turkey bacon.
if you're ever wondering if somebody needs to go see a doctor. One of the situations in which they absolutely do is when you can't get a wound clean with just that gentle spray of water. If there's still any kind of dirt or anything in there, they have to go be seen by a doctor, even if it's a minor wound, even if the bleeding is stopped. Because that needs a medical professional to do further cleaning. Otherwise, they're gonna get an infection.
I don't know the research that company needs to do it.
Okay, so guys, we hit two of the main three factors, okay? We've got airway. How we gonna address their airway? By doing a what? How many times? Okay. We're gonna move on to the bleeding. How many different types of bleeds am I looking for? How do I address that? Exactly. And if we don't address the bleeding, that could lead to possible shock. So we got airway obstruction, bleeding, and shock. This is the extent of what we're going to be doing at search, guys. Okay? Let's talk about what shock is. Shock, you said this earlier, result of ineffective circulation of blood. Okay? Remaining in shock will lead to death of the cells, tissues, and organs. So, just to kind of give you guys an example, shock doesn't look like someone laying down like this with blood coming out. Shock can look like this. I'm here. I'm breathing. I'm sitting up. There's no blood flowing, but I can still be in shock. How could I possibly be in shock at this moment?
Internal bleeding.
Internal bleeding. What else?
Just something mess with your mind.
Huh?
You just seen something.
I'm seeing something.
Yeah, like you just seen something, like somebody just got like flattened out by a piece of, you feel me, like roof or something.
Exactly.
Something traumatic.
Exactly. So now we're kind of putting this stuff together. What Chetler was just saying, I could have had some type of injury. So how could I determine that? If I wasn't there, what could I possibly do to determine by looking at this person if that's possible? Do what? I'm not responding.
With their eye.
Those are all symptoms, but for me, what can I start doing initially to make me say, okay, what's going on with this guy? You guys already have the information. What's the first? What are we going to be doing a lot?
Check the breathing.
Assess the situation. As I'm approaching this person, I'm looking to see if the scene is safe, right? I could see a piece of roofing right here. Close to this guy. I can see a gash on their head. Well, you know what? That's the reason why, even if we weren't there, your scene size up, your constant assessment, using your senses are all super duper important, guys. Because we can get some assumptions that aren't detrimental by simply walking up to the scene, approaching the scene, okay? This is how we recognize shock. Rapid and shallow breathing. Physically, we should go see this. That's rapid, shallow breathing. Yes, sir. It can be. It's a symptom, right? But, you know, food poisoning, some type of food poisoning, and that means that I have food poisoning, right? This means that I have a stomach, so it's just one of the symptoms, right? You start talking about strokes, there's different things, different parts of the body might become paralyzed, aphasia, things like that. So again, rapid, shallow breathing. Capillary refill, which is greater than 2 seconds. I want everybody to do this right now. I'm gonna show you guys how we do a capillary refill. Right? You guys know what it is? Who knows what that is? What's a capillary refill?
Capillary refill is basically how fast the blood goes back to go under your nail.
Exactly. So guys, let's practice that on ourselves. A few ways I want you to do it. I want you to take your finger, put it right over the top of the nail, press it down, it should turn right and count. 1, 2, and see how long it takes to go goes back right. After the second, I hope everybody's is less than 2 seconds in here. So you guys see that? So you'll press it, it'll start turning white. When you release it, it'll start turning that crimson pink. You guys got it? Yes. Huh? Oh, you can still press it. It's just the pressure.
You can't see.
Oh, so watch this. You got the fingertip, you can press that and count it. It's other things we'll address too. Nail polish, same thing. You can hit the fingertip. You can also use the palm of the hand. The nail bed is the preferred method, but if the person has nail polish on, they had a pedicure and a manicure, right? You have to start moving on to different things, right? Fingertip, palm of the hand, bottom of the foot, depending on the ethnicity. With me, it won't be that great, but the ear, the inside of the lip, if I would use that very last, you won't be putting your hands, especially now, in nobody's mouth. I'm just putting that out there for you. Okay?
Well, I always like to really emphasize, and I tell our firefighters this too, that third bullet point, failure to follow simple commands. Even more strong, I'd say, if someone seems to be confused, I want you to have a real high suspicion that shock is going on. Because remember, shock is, you can have plenty of blood, it's just not circulating well. And there's 4 different big kinds of shock. It isn't just from injuries. And sometimes bleeding, you can bleed out so badly into your thigh or your belly that you go into shock even though you're not bleeding externally at all. But if somebody seems at all confused, keep a close eye on them and look for all this other stuff. So, and one thing that can happen too, and remember, all this is in the context of having multiple patients, right? Where you can't spend a lot of time with each one. You need to go back and check these things regularly, every 5 or 10 minutes, because it may take a while for ambulances to show up and take these people to the hospital. And especially somebody who wasn't confused and is becoming confused, giant red flag. And you need to bump them up in terms of the priority to get them treated. So what's going on there is your brain is extremely sensitive to getting enough oxygen and enough sugar. And your bloodstream is what delivers sugar and oxygen to your brain. So if your blood's not circulating well, that's shock. Brain starts not getting enough sugar and oxygen, people start getting confused. Sometimes you can't tell if this is somebody's normal state. So here's a question for you. You get some person, you're out in the community, it's a disaster, and here's this person, and they're acting confused. How do you know if that's normal for them or not? If you've never met them before. Ask their friends or family, right? Is this person acting normally? Hopefully somebody is there, right? And then if the answer is no, that's not the way they normally are at all. Bing, 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 bing. Now you're really worried, and you're gonna prioritize this patient because that's not normal for them. If there's no family and friends around, I think, they're really acting confused, you just have to use your best judgment and assume that, hey, maybe this isn't normal for them, so just to be sure, we're gonna up them in the priority. And we're gonna talk about all the priorities for triage. Because this is all under that heading of triaging people when there's multiple people injured and you're deciding how to prioritize them. Who's gonna be taken care of first, and who's gonna go to the hospital first, and that sort of thing. Good question.
I was just gonna ask, what are the requirements to become a firefighter?
Let's talk about that, maybe at the end. I think we'll probably have some time left over.
Okay, symptoms are shock are easily missed. As Nick was saying, so, you know, pay close attention to that. We're gonna go into some of this stuff a little bit more. Okay. So, ways of retreat for shock is to maintain an open airway so they can breathe, so the blood will flow to get the sugar and oxygen to where it's supposed to be. Control obvious bleeding. Again, when we are doing this, what phase are we in?
Phase one.
Phase one. Phase one takes place when we're doing what process? You haven't done this module yet, but I've been talking about it.
Assessing?
Yes, but what part?
Assessing the situation? Assessing her condition?
Search and rescue. This takes place during the search and rescue. When I first begin my triage, that's when it takes place. This whole process that we're doing, checking the airway, the bleeding, and the shock, you have 30 seconds to determine that. And I have this little thing that I'll show you guys later, and it's called 32 can do. And that's addressing the airway, it's addressing the bleeding, and it's addressing the mental status. And you guys are gonna see what those numbers are going to do. I've been doing this since I've been teaching it, but definitely recently with some classes. If you guys can remember 32 can do, I can guarantee you will be able to get dispatched or go to a scene when you're comfortable, and you will be able to start taking care of people. Once you actually understand the 30, the 2, and the can do, you won't be afraid, okay? You want to control obvious bleeding, maintain body temperature when you suspecting someone to be in shock, give them a blanket, you know, keep them warm. Avoid rough or excessive handling. Don't give them any food or any drink. Why not?
Choke.
Exactly. If they decide they want to go down at that point, they can choke. And I don't think that we're necessarily doing the elevate 6 to 10 inches anymore. Nick?
Well, they found that you have to elevate the feet way more than that to have any effect at all, and it doesn't really have much effect. Big thing is keeping them warm.
Okay. And there it is. Responding to a mass casualty event. Guys, have a plan. I would rather have it and not need it than need it and not have it. Have a plan. Guess what, guys? Follow that plan. Because that plan has already been set. Third thing, document your actions. Here's the deal. If you don't document it, it didn't happen. That documentation is how you're going to protect yourself. During a disaster, this napkin, I'm out here, put this person's vital signs on here, I did this. Guess what? Where's my legal document?
That napkin.
This napkin, toilet paper, shirt. It becomes a legal document, and they will file that away. Okay? You chop your hand off, man. So, if you do write it on your hand, which is a good idea, transfer it. Guys, you have to document everything that you do. And when you guys go into your organization, some of the stuff that I'm telling you guys, I'm mentioning right now, they'll go in thoroughly in some of your other modules. But you're gonna see this. You guys have a module that's specifically talking about that. You have to document that. They'll go over some things with you guys, some little shortcuts of how to do it. But documentation, you have to do that, guys. Very important. For you, definitely when we go into the second part, medical operations part 2, and you guys are actually transporting these people from where you're triaging them to the medical treatment area, you're gonna have to drop that patient off. You're gonna have to have a very good description of the person that you're putting over there. You wanna pay close attention to approximate size, height, age, clothes that they're wearing, jewelry, scars, tattoos, medical bracelets, things like that. You want to pay attention because from this area, these people are going off to hospitals. Okay, if someone asks you or needs some information, I don't know, I don't remember, right? Doesn't look really good, okay? So again, document. What's the first thing I'm gonna do when I'm approaching the scene, guys? Okay, I said, you're right, but there's some specific things I wanna hear. First thing I wanna do is do what?
Make sure you're safe.
And what?
Got your PPE.
Exactly. Beautiful job. Okay, here we go. Cert size up. You guys hear me say that a lot today, right? Cert size up, assess, pretty much the same. Gather facts, guys. And you see this? This is what Nick was talking about earlier today. This is constantly happening. This is constantly happening, guys. Gather facts. That's it. That's what we know. Those not assumptions. These are the facts. Gather the facts. Assess the damage. What has happened? How bad is what has happened? Consider the probabilities. Well, if that part of the building fell, that side is unstable, so that side is probably going to be falling next. Example. Consider the probabilities of your damage assessments, guys. Assess your current situation. Do I have the manpower? Do I have the supplies? Is it safe? Establish your priorities. Okay, what's most important? Exactly, but now we're doing a cert size up, we want to establish the priorities for this particular venture here, okay? What's the priorities for getting people moved from this building to the next building? Is it a priority, right? Establish your priorities. Make decisions, guys. You know, you have to say it and then act upon it.
I feel like a lot of people fight against this stuff, though.
They do, but you're right. That's exactly the reason why I said make decisions in there. Because otherwise, if you sit down, you sit on the fence, you're going back and forth, you're wasting time. Nothing is getting done. Okay? Plan of action. Develop a plan of action. Okay, I've gathered my facts. I assessed the damage, and I feel pretty safe about doing this. My situation is I have enough people, I have the manpower. Moving these people from here to there are priority. I'm gonna make the decision to do it. My plan of action is I'm gonna get, what's your name, brother? Eno? What's your name, young lady? Sophia. Enoch, Sophia, and Chippy. Okay? What I'm going to do in my developing my plan of action, they're going to get approved, and they're going to move these people from here to there. We need wheelchairs. We need just assistance. They're gonna go help. Develop a plan of action. After I develop that plan of action, by having them do that, they're taking action. After I take action, I'm gonna evaluate my progress. Why am I doing number 9?
Well, say you already got something done, now you have to look at what other options you have to do now.
Exactly, and to also do what else? That is correct.
Also to assess if there's any additional assistance that you need, or you have too many people in your group to take care of.
Yes, but look at that. Did it work?
No, it's just progress.
Well, it could be progress or it could not be progress. That's why we need to evaluate the progress. Because if we don't have progress, don't we need to do this again?
Yeah.
You see what I'm saying? That's the importance of evaluating your progress. Part of evaluating your progress, that's what keeps this as a continual process. Because what I'm doing right now, I might not have to do 30 minutes from now. And if after I'm taking action, my progress is successful, then guess what? That's gonna change. Is that making sense, guys? Make sense? Nate? What is triage? It's a process for managing mass casualty events. Remember, triage means to sort by priority. Survivors are evaluated. They are sorted by urgency of treatment needed. What are the 3 things that we address? What are the 3 killers, guys?
The airway, breathing, and shock.
Okay. The survivors are set up for immediate or delayed. You're gonna watch a video right now, and you guys will see. Now, all the stuff that I've been talking to you guys about is really kind of be summed up, not kind of, it's going to be summed up in this video. Simple triage and rapid treatment, okay? You guys are going to see the pharmacist go ahead and make his announcement, and watch him do what he does and how fast he does it.
All consent up there with. Sir. Ready?
Yes, sir.
Every multi-casualty incident is a race against time. When many people are injured, how we respond can make the difference between how many victims survive and how many die. START, the simple triage and rapid treatment system, enables rescuers to do the most good for the greatest number of victims in the shortest amount of time. START training will help you save lives. Triage is a system for sorting victims so the most seriously injured can be treated and transported first. Most rescue plans call for triage in a multi-casualty incident, but they don't tell you how to do it. We will. In this video, we'll help you learn START, simple triage and rapid treatment. Your START training will enable you to take charge when you're faced with many casualties and time is critical. START training will teach you how to do 3 important things. What to do when you first arrive at a multi-casualty incident. How to assess an injured victim in less than a minute, so that you can prioritize victims into 1 of 4 treatment categories. In this video, we'll use a triage tag with 4 categories: minor, delay, immediate, and deceased. Each category is a different color. The colored strips are removed, so the last color remaining on the tag shows the patient's classification. Get ready. Get set. Let's start.
Police Engine 5, Newport Medic 3, respond to a traffic collision with injuries, Grid 39, Avocado and Coast Highway.
It sounds like a routine call, but are you prepared to respond to something like this?
Central 19 Engine 5 at scene, two-vehicle traffic collision on Harvard's the transit bus. Stand by for additional resources.
Montana Fire Control,
Full reconnect.
safety measures are your first priority.
Alan, let's make access to the bus and start patient triage.
We got 2 people in the car, we got about 20 to 30 in the bus.
Okay. Central 19 Engine 5, assign 3 medical task forces and 1 truck company.
The company officer calls for additional resources and will continue to evaluate the scene. The START method is the answer to the first responder's question. What do I do now?
Okay, officer, need you to back away from the glass as much as you can. Cover your faces. Cover your face.
Seconds with this type of noise. 30 seconds. Walking wounded, divorce triage. Just use the walking wounded to help him.
incident and you're all revved up, just remember RPM. Now we'll learn how to use RPM to assess each patient in about 30 seconds. Respiration is the first assessment because it is the most critical function. If the patient is not breathing because of an obstructed airway, attempt to clear the airway. Depending on the type of obstruction, either reposition the patient's head or remove any debris that may be lodged in the throat. While repositioning an injured patient's head may be contrary to what you've learned about cervical stabilization, Dr. Greg Super explains how to handle a patient who's unconscious and not breathing.
If we do nothing, he's a certain field death. If we open his airway, we may aggravate an existing cervical spine fracture. We chose to make that intervention. If we open his airway, he makes attempts to breathe, and we can keep that airway open, he may have a chance to survive. If we leave the airway closed, he has no chance.
If respiration cannot be reestablished with these simple measures, don't waste time attempting CPR.
The first rescuer's basic instinct might be to begin CPR on the first one he encounters. That would be a mistake. These people die. If the first rescuer goes to CPR on the first victim he finds in full arrest, he will not be available to help those who still have a chance at living.
Non-breathing patients are considered non-salvageable and are categorized deceased. Move to the next patient.
Okay, need help over here? Need help support his head? Okay, just like this. Need you to help keep his airway open. Just like that, okay? Great. Let the airway close.
If the patient begins breathing after the airway has been cleared, categorize immediate and move to the next patient. To assess respiration on a patient who is breathing, observe the frequency of respirations. Patients who are breathing at a rate of more than 30 respirations per minute are categorized immediate and no further assessment is done. Move on to the next patient. Although you won't take time to actually count respirations, you can become skilled in visual assessment by watching others simulate rapid breathing. With practice, you will be able to easily differentiate between a person who is breathing faster than 30 respirations per minute and one who is breathing at a normal rate. If a patient is breathing slower than 30 respirations per minute, proceed to the next assessment, perfusion. Here's how the respiration assessment looks on the START flowchart. If the patient is not breathing, reposition the airway. If breathing does not resume, the patient is non-salvageable and is categorized deceased. If breathing resumes after you clear the airway, categorize the patient immediate. Patients who are breathing at a rate of more than 30 respirations per minute are categorized immediate and no further assessment is done. If the patient's respiration is slower than 30 respirations per minute, proceed to the second assessment, perfusion. In a multi-casualty setting, the capillary refill test is the fastest and most effective way to check perfusion or circulation. To do this, press down on the patient's nail bed and release the pressure. The skin underneath the nail should return to normal color within 2 seconds if perfusion is adequate. If it takes longer than 2 seconds, categorize immediate and move to the next patient. The radial pulse can also indicate perfusion status. If you cannot feel a pulse, the systolic blood pressure has probably fallen below 80. The patient's legs should be elevated to improve blood flow to the heart, lungs, and brain, and the patient categorized immediate.
Put as much pressure you can there. I need to stop for bleeding, okay?
In situations where a patient has severe external bleeding, direct the patient or a bystander to apply pressure to the wound. If the patient has adequate perfusion, proceed to the third assessment to check mental status. On the START flowchart, the perfusion assessment looks like this. Check capillary refill by pressing down on the patient's nail bed. If color does not return within 2 seconds, categorize the patient immediate. Elevate the legs and control bleeding if necessary. If the patient has adequate perfusion, the nail bed capillaries will refill within 2 seconds and you will proceed to the third and final assessment, mental status.
What's your name?
Brain injury accounts for half half of the deaths and disasters, patients with altered mental status are categorized immediate. You may have already observed the patient's mental status during the first two assessments. If the patient is unable to respond to simple questions or commands, categorize immediate.
My leg, over here, my leg. Oh God, I think it's broken. I
Relax, just relax, okay?
Get me
You're
out of
breathing
here.
fine, breathing fine.
Get me out of here. Please, my leg really hurts. It
Okay,
really
you got a
hurts.
good pulse, got a good strong pulse. What's your name?
Jan,
Okay, Jan, what day is it?
Friday.
Friday, good,
Please,
okay.
it hurts. Oh God.
We're far to coming, okay? We'll get you out of here as soon as possible.
Hurry.
All right, I've got help coming.
If the patient can't follow simple commands, categorize delayed and move to the next patient. Here's the mental status assessment on the START flowchart. If the patient fails to respond to simple questions or commands, categorize immediate. If the patient can follow commands, categorize delayed and move to the next patient. The delayed category does not mean the patient is not injured and does not need treatment. It means the patient isn't at high risk of early death. As you have seen, every patient is triaged and categorized depending on the need for medical attention at the time of assessment. Immediate patients need to leave the scene as soon as transportation arrives. In this video, you have learned how to direct the walking wounded away from the scene to reduce the number of patients you need to assess, how to use bystanders for rapid treatment of severely injured patients, how to start where you stand to begin patient assessment, how to use RPM to rapidly assess a patient's respiration, perfusion, and mental status, and how to use a triage tag as a method of categorizing patients.
Okay. So, they're pretty much putting in perspective what I was talking about earlier in regards to, you kind of put this whole thing together, the walking wounded. On, just to kind of address some things, when they ask the name, so I don't know this person's name, and if they actually have an altered mental status, they're telling me their name is Jim, but their name is Bob. I don't know if it's Jim or Bob. So follow up with some additional questions. I would ask for the name just as a comfort thing when I'm talking to them, so I can call their name. But follow up with some additional things like the fireman. Do you know what happened? Do you know what day it is? Do you know who the president is, right? Because simply asking someone for their name and trying to use that as a way to judge their mental status might not prove to be the best. Okay? Because again, if the mental state is altered, they can be telling somebody else's name, grandparents' name. Okay? So the triage, those tags that they're talking about, just in case that comes up in here later, because it possibly will. I don't have my bag today, but I'll bring it on Friday. I have tape, and it looks like caution tape, and it's on a little spool, and it has red, yellow, green, and black in it. Even if you didn't have that, now I just want to get you guys to think. Just say if I don't have any of this stuff, I don't have the triage tag, but I needed to mark this victim or this patient. How can I mark them? What can I do? Do what? Exactly. I'm gonna use the letter I, D, M. This one right here, I might put M for Lord. You know, because we got D for dead and D for delayed.
But there's also M for minor. Spell the whole word.
Oh, you're right. I didn't get that. Well, spell it out. Get creative. You guys get what I mean with this, right? Good catch. Okay, so did you guys get that? Okay. So red will be immediate. Survivor has life-threatening injuries, airway obstruction, bleeding, or shock. Delayed, the person is injured, they're just not immediate, right? But can they change? Oh, they're gonna stay the same.
You can change to immediate.
Exactly, it can change to immediate. Now, these guys right here are awesome because we can use these people. What can we use them for? Help. So what else? Assistance. What else?
Go get help.
Who?
To get help. More help. Or what?
Yeah, they were just talking about the ways that they can help, but what else can they do for us? And it's also helping. But just one thing in particular I'm just kind of looking for. They can help assist us. They won't be actually triaging. They might be applying pressure. Information, which is super important, okay? These walking wounded can give us information. Now, I'm just kind of touching up on the video again. The first thing that he did, the first thing that we're gonna do is call a what? When I'm approaching the scene, start where you stand. But the first thing I'm gonna do is call a
911.
a voice triage. Because I'm triaging people with the sound of my voice, right? 9 people came out of there. You did not have to go up to those 9 people and do anything. If you can hear me, walk to the sound of my voice. Come to me, whatever. And they came. They have just been triaged. That's 9 people. That was 15 people there, right? Get a specific or designated area for them to go to. Team members, have someone watch them. Is it okay if someone in the green walks off? Is it? She's like, yeah, no, it ain't. No, it's not. Yeah. So, right, it's still wounded. So we don't want them to walk off. But if they do walk off, can we stop them? Exactly. Just be clear about that. We want to keep an eye on our walking wounded as well, right? Injuries have been known to show up later. If they fell and they hit their head, they might have actually even gotten knocked out and briefly and recovered by the time we get there, right? So those things have happened, and that could be some type of internal injury, and they end up passing out later down the line, okay? So again, immediate, those people are going right away, they will be addressed. Now, I'm gonna help you put this together. When am I doing this? Where does this take place? Phase?
The first phase.
1. Because remember, where was the fireman at? He was at the scene of the accident. Triage takes place at the scene of the accident. That was to happen to be an accident involving vehicles. This could be an accident involving a collapsed building. But the triage takes place at the scene of the accident. We're not treating right there. Just say if a person had a leg injury. I'm not gonna split them right there. I am gonna triage them only so I can get them labeled. Then, when I get my rescue team in there, I already know. I have 3 reds, I have 4 yellows. I know where they are. I know I have a general idea of what's wrong with them. And from there, I can decide how I'm going to transport this patient from the scene of the accident to the treatment area, which we're going to go into in medical disasters part 2, okay? Rescue safety during triage. If hazmat or terrorist event is suspected, we do not respond, okay? We're not hazmat specialists, we're not terrorist specialists, we don't respond to that stuff. However, if we do suspect something terrorist-wise, evacuate as safely as possible, okay? For a terrorist incident, if you have to evacuate, we were talking about this in class the other day, miles away, 5 miles away is not a bad idea to shoot for, okay? It's part of by safety. Always wear your personal protective equipment. Nick went over some of this stuff earlier, your helmet, goggles, N95 work gloves, sturdy boots, and non-latex gloves. Okay, here's our triage process. When do we do triage again?
As soon as you step onto the site.
And before I decide to do triage, what do I have to make sure of?
That it's safe for us to go in.
Exactly, and that I,
That's what you got.
beautiful. Now, remember I was telling you guys about your sensors? All the stuff that I was telling you guys about earlier, you've been able to insert that right now. I want to stop, look, listen, and think. Step 2, there's that voice triage. You can hear me walk to the sound of my voice. Here it is. I'm going to start my triage where? Okay, and follow a systematic route. What that means is, and you guys will go through this with your search and rescue. I go in the building with my search and rescue team, and I decided I'm going to do a left sweep for my search. I'm going to go to my left, but I hear somebody in the back to the right. You don't go. You stay moving to the left, and you continue to move in that systematic route until you get to that person, right? Because what did it say in the video? You really don't know. I know people that get a scratch, man, and it can make a lot of noise, and you'll think there's something major going on, and it's absolutely nothing. So, some of this stuff is key, guys, when you're addressing this. When we're talking about the 32 can do the skin perfusion. So when I was talking about the 32 can do, that right there is gonna help you guys get through your triage process real fast, okay? It's gonna help you to be able to get that done within those 30 seconds, okay? You're gonna evaluate each survivor and tag. You're gonna treat immediate survivors immediately, and then you're gonna document your triage results. Here's my evaluation. Check airway and breathing. Check circulation and bleeding. And check your mental status. Okay. Here, this is some of the reasons why our triage process doesn't work. There's not a team plan, no organization, and we don't have a goal. Triaging, what is the plan after we get the triage? Where are they gonna go? How often are we gonna get a chance to come in and evaluate these people again? What's my manpower like? How am I gonna keep that consistent? Okay. Indecisive leadership. I'm not sure, how we're gonna do this. I'm not sure if I wanna be managing here the treatment right now. Indecisive leadership. Jeffy!
What happened?
Too much focus on one injury.
Too much.
Too much. You don't want that, guys. Because what's the mantra in here? To do what? The greatest.
Greatest good with the shortest amount of time? Or like as much as you can?
The greatest good for the greatest amount. The greatest good for the greatest amount. Close.
You got tomatoes, you know what I'm saying?
Potatoes.
Potatoes.
Okay, and here's another one, right here, guys, a key one. This is triage. What does it say? Treatment rather than triage performed. Because where are we doing the triage? Where does that take place? Come on, young people. Where do I do the triage? Don't be afraid to speak up, say it. I heard it.
What was the question?
when do we do the triage?
Where the accident takes place, no?
See?
Where the accident
Exactly.
takes place.
Exactly. Triage takes place right at the scene of the accident. I'm not treating right there. I'm just trying to see the level of injuries that I have. I'm only triaging. I am not treating. And this is why they say we have triage pitfalls, because instead of triaging, I'm treating. Okay? What are the three killers? Guys, don't be afraid. Speak up. There's no wrong answers. Okay? What's the technique for opening the airway? Oh. Exactly. What's the best way to actually control bleeding? Direct pressure. Why am I trying to control bleeding?
So that they won't go into shock.
Exactly.
Or so they don't die.
Yes. Which will lead to death, yes. Okay. And you guys should actually be able to conduct triage under simulated disaster conditions. Questions? Somebody got one question. Yes, sir. Great question. This young, what's your name again, man? Enoch. Enoch just asked me, so after triage, what do we do? That, my friend, comes in medical disasters part 2. These people have to get out of this bus, right? That's where the second part comes in. We're gonna address that a little bit later. Any more questions? That's not off the table. Any more questions? Okay.
Okay, we're gonna take an 8-minute break, so let's see, we'll be back here. How we deal with it. And so, Derek was saying that there's like 3 treatments we do in CERT. That was in the context of having a triage situation. Outside of triage, we do a lot more than just those 3 treatments, right? The 3 treatments, of course, were opening the airway, extreme bleeding, and life-threatening bleeding, and shock. So we're going to talk about other medical stuff that we do for bleeding. In a triage situation, those are the only 3 treatments. So there's nothing more we can do. And we said, we warned you that we mentioned this a few times because it is really important to stop now and then. Maybe even take a deep breath because slowly exhaling actually slows down your heart, lowers that stress response so you can think a little more clearly. One of the things that our brain does under high stress is we get tunnel vision, we zero in. That's why one of the pitfalls of triage was you get so focused on one person and start doing too much treatment, going beyond those 3 things, because our brains just kind of naturally get that tunnel vision and we sort of forget everything else going on. That's also very unsafe. In a wildland fire, you get super focused on taking care of the patient. The fire can sneak up on you. So you want to get in the habit of just stop, take a breath, work around, have the situation change. And I really want you to memorize this ongoing planning process. I talked about how at fires, every 24 hours we come up with a new plan. That's for the whole fire. But maybe every 10 minutes in a very fast changing situation, we might stop, look, what's going on, considering probabilities. So this is things like, there's been an earthquake, and you're going down your street and you notice that the next block, all the lights are on, right? The lights are on back here, the lights are off over there. What's the probability that you might want to think about?
Power lines.
Power lines down, right? You might get electrocuted, right? So now it's dark, you can't see, so one of the things I always have in my pocket for one gloves is a flashlight. It's down there. And now, you know, seeing that the power's on here but not over there, there's probably a power line down somewhere, and that's a probability to watch out for. So the more you sort of stop and think about, okay, what might be going on here, very important. So that's assessing your situations. And you may have to frequently shift priorities. Remember what's your first priority? Yourself. What's your next priority? Very good. That's good. That's yourself and your crew. And then it's doing that greatest good for the greatest number of people. That's the priority. And once you have your priorities, you can start making decisions about how you're going to deploy the resources you have, come up with your plan, execute on that plan, and then stop, think, hey, how's the plan working? Go back to what's changed and so forth. So let's keep doing this, and we will come back to this. All right. So,
I'm just not seeing your text.
To protect public health.
I'm just not seeing your
We're
text.
doing this a lot these days, huh? In our fire camps, one of the things that the C's, the California Conservation Corps, is doing all the time, I don't know if this part of your work, is cleaning. They're wiping down the handles to the porta potties, they're wiping down the tables, the door handles to all of our tents.
My text is going off, I won't look at it. Yeah.
But
I would know what that means.
we used to, in fire camps, get this thing called camp crud.
I didn't check it, Colin. I'm like, I felt it vibrate. I'm just not checking it now. I heard it up there. I'm like, I'm working. Don't bother me, Colin. I'm working.
Or worse, something like norovirus, where they're vomiting or have diarrhea or something like that. Usually not as big an outbreak, but it's super contagious. Here's the wonderful thing about all the stuff we have to do for COVID. Nobody's getting camp crud. Everybody is staying healthy in camp, so our fear is that they're going to make us continue to do all this even after COVID is behind us. Because, as you can imagine, when we need every firefighter we can get, and we start losing them to camp crud or other illness, that makes the fire that much harder to fight. So one of the sort of superstitions around that is our dinner's usually served out of a big trailer, kitchen unit, and there's steps to go up to the window where you get your dinner, right? And there's a railing next to the steps, and so the big superstition is don't touch the railing. If you touch the railing, you're gonna get cancer. But we make everybody wash their hands before they go into their meals and just the constant. So, and sanitation really, really, really suffers in a disaster because it can be a lot harder to stay clean and stick people into shelters where they're right next to each other. It's real easy for illnesses to transfer around. Really, the same thing that happens in our fire camps happens in the shelters, where 7 to 10 days into the disaster, the people all live in close proximity in the shelter. Very often, everybody's coughing and sneezing without COVID, or worse, things like norovirus, which can be the nastier stuff too. So, sanitation is real important. Maybe because of COVID, a lot more of us have bleach and cleaning supplies and wipes and all that stuff and masks and gloves, and we'll do better in disasters having sort of being strengthened by the stress of COVID a little bit there in terms of our ability to protect public health. We're going to talk about how to evaluate a patient from head to toe. This is not something you do during triage, but now once you've got people out of the vehicle or building or wherever they were hurt and they're in the treatment area, or you just encounter a patient outside of triage, kind of take a look at it. Put together that treatment area that you're going to take people into from triage. Splinting, suspected fractures and sprains. So splinting is real simple. If you can keep a broken arm or a sprained arm or leg or anything else, if you can keep it still, it won't hurt too much, and it won't be further damage. So splinting is just a name for how we immobilize. Let's say it's the arm. Because if you can splint it so that it's in a relatively comfortable position and it's not moving around, not only will it not get injured more, but the person's going to feel a lot better because it's really just a movement that hurts. It will stay still, it doesn't hurt. So, in talking about public health, how we operate medically, in different areas. I don't know why they put the same thing on the next slide. Wound, burns, wound care, talk about that. Ankle injuries, cold, heat, like some singing. So, hygiene. Wash your hands wash your hands, don't touch your face, I just touched my nose, didn't I? So on fires these days, because of COVID, we are constantly reminding people to wash your hands for 20 seconds, which is long enough to sing happy birthday, with soap and water. So the outside of a virus is covered with fat. And if you've ever washed dishes, if you've got greasy dishes, and you wash in plain water without soap, they're still greasy, right? The virus is the same way. What is on the outside of the virus is like grease. So if you just rinse with water, yeah, you'll rinse some of it away. But if you wash with soap and water, the soap actually breaks down that lipid barrier around it, and it is way, way, way more effective. So 20 seconds, soap and water, happy birthday, and so forth. Purifying water. So sometimes our water systems get contaminated in a flood. Very often, water systems get contaminated. And so there's times that we have to purify water by boiling or filtering or something. And talk about preventing spreading disease. Oh, look at that! Wash your hands frequently. Imagine that. Or alcohol-based hand sanitizer. So this was all written before COVID. I think everybody knows that now. So gloves are there to protect you primarily from contact with other people's bodily fluids. Other people's bodily fluids are not something you ever want to be in contact with, period. N95 masks and goggles. Some kinds of interesting things spray. I'll just leave it at that. No need to go into details. If there's anything that can possibly spray at you that somebody else's bodily fluids, you really want to be wearing gloves. Dressings. So a dressing is the thing you put directly on the wound. A bandage is what holds it in place. Right? A Band-Aid is a dressing and a bandage all in one. But those dressings, the one that go directly on the wound, those need to be kept sterile. So keep them in there protected action. And or contact with body fluids. If it's warm, wet, and not yours, don't touch it. Rashes, one of the first things I learned about rashes is if they're dry, you wet them. If they're wet, you dry them. But above all, you don't touch them.
Wait, what was that about rashes?
Rashes.
You said.
If they're wet, you dry them. If they're dry, you wet them. But above all, do not touch them. That's one of the first things I learned in an emergency room a long time ago. Sanitation. So, if you got stuff that could have bacteria on it, so anything that's been in contact with somebody else's bodily fluids, again, you want to be careful how you dispose of it. We have these fancy red bags that are for disposing of biohazard material, and so we'll put that. If it's a small quantity, sometimes we'll just put it in an ordinary plastic bag and put it in the trash. It's a very small quantity. But if it's more than a tiny, tiny bit, we put it into these biohazard red bags and dispose of them as biological waste, which is a whole separate system. So don't mark them as medical waste and keep them separate. And then if there's no other way to get rid of human waste, we want to bury it and bury it reasonably deep. Unfortunately, wildland firefighters, a lot of times we end up out in the woods with no porta potties or anything, and so you'll see firefighters marching off into the woods with a shovel and roll of toilet paper. Water sanitation. So boiling water for 1 minute will kill pretty much everything. You can buy water purification tablets. So the outdoor stores like REI and Sports Basement, those have water purification tablets. They also have filters that you can use. Like Costco, at least a little while ago, was running a sale on this thing called a Life Straw, where you suck water through it and it cleans it as it comes through. There's ultraviolet gizmos that are battery powered, and you put it in a glass of water. It takes, I think, a few minutes, and it'll kill it. But you can also use non-perfumed liquid bleach, so straight bleach, like straight plain Clorox. 8 drops in a gallon of water, or if the water's cloudy, 16 drops. Let it stand for half an hour. Then it's safe to drink. You may taste that chlorine a little bit. It might taste kind of like swimming pool water, but it's safe. You don't need more than that, but it is safe to use at home. So, we've been talking about triage. We'll talk a little bit more. So that's the ambulance system, right? For some multi-casualty event. So triage is that initial sorting, right, where we only do those 3 treatments, and then the larger treatment that we're about to talk about some more. And then transport to wherever they need to go, whether it's urgent care, hospital, whatever. Or we can talk a little bit about setting up a morgue, a place to put people who have died. Ideally, that's out of sight. And supply. So you can't do medical care without having medical supplies. So that's part of the whole system as well. So establishing a medical treatment area. So as soon as you know that you have a number of injuries, you want to create this treatment area. But you want it to be somewhere safe. You don't want to put it in the middle of a freeway with cars going by, or where there's going to be a lot of pedestrian traffic coming through. So out of the way, but also in a place where ambulances can get in and out, where it's not going to be too hard for you to get the patients from where they were hurt to this treatment area. Somewhere that's safe, so if there's been an earthquake and there's damaged buildings, you want to be away from them, away from damaged power lines. If there's a hazardous materials incident, you need to stay away from that completely, but you want to be uphill and upwind of any kind of hazardous materials, or smoke, that sort of thing. So, safe area, free of hazardous debris, uphill and upwind. Look at that, uphill and upwind, accessible to ambulances, and able to expand it because remember, we're doing that size up all the time because you really don't know what you have right away a lot of the time. You might suddenly discover, holy cow, we got like 20 more patients than we thought, so this needs to be able to grow. So you want, a football field or something that's great because you have lots of room to grow it if you need to. So, sometimes if you've got a wide area disaster, you might treat everybody in one location, but you might also have multiple treatment areas, just based on how hard it is to get patients from where they were injured or sick to where they're going to be treated, and the ability to get things like ambulances and other vehicles into there. So we've got 4 treatment areas that correspond to those 4 levels of triage, right? Immediate, delayed, minor, and the black for the ward. So St. Clair County has a number of big disaster medical trailers, and they have, see the tarps here? They have the red, yellow, green, and black tarps. And we usually set the first 3, the red, yellow, and green tarps right next to each other, and even have little flags so you can see them in the distance. And then the black one somewhere out of sight, like this. Nobody really wants to see that. And as people come out of where they were triaged, they get set down according to the color of their triage tag, and that's where the further treatment takes place. So, let's say this is a building where people got hurt.
Both of these
There's people out in the treatment area, there's red, there's yellow, there's green. We stick people in there, or kind of far away, and then transportation access. And an important thing about that, is if at all possible, we don't want vehicles to ever have to back up, period. Backing up is dangerous. On fires, we are constantly reminded of how dangerous it is to back up. We're supposed to always use a backer, which isn't always practical. We had a firefighter killed last year on the August complex up in, so it's probably Mendocino County, no, not Mendocino, up north, west of Red Bluff, when she backed her son's fire engine into the fire. We don't know exactly how or why she did that. Thinking maybe again brain fart. She was trying to turn it around, get away from the fire. The fire kind of jumped up on them. Her son has a contract firefighting company, and she flown in from Texas to work with him. She decided to try to save the engine and just backed up off the edge right down into the fire. So backing up is dangerous. So notice that here, nobody has to back up. So the ambulance can come in here, stop, load a patient, keep going the same direction. It might seem like a little thing, but it's super important. So each area, red, yellow, green, should have a treatment leader. And we need to be constantly reevaluating people to see, especially to see if they need to move to the higher level. Somebody who's a yellow right now, maybe become a red, right? So they were conscious of the Lord, but now they're starting to act a little confused. They gotta move. And somebody's gotta be there in charge, monitoring those patients, taking care of them, giving them what they need, and moving them. And occasionally they move the other way. Somebody could go from yellow to walking wounded, something like that. Like the guy with the tourniquet, he was a red until he got the tourniquet on. And then he became, I don't know, either yellow or green. He probably yellow at that point. So documentation. So Derek talked about it is important to, as you create a record, to describe that person in a way that they can be re-identified, especially if they can't give you their name, or if their name is something really common. If it's John Smith, there could be a few of those. So a description of them, what they're wearing, what their injuries are, how they've been treated, and where they're going, but also realize in this kind of situation, an ambulance or other vehicle is transporting them, they say, you know, we're taking them to Kaiser St. Clair, and they may end up at Stanford, because in a disaster, patients get rerouted all the time, because emergency rooms fill up, hospitals fill up, everything changes. So no guarantee that just because they thought they were going this place, that they actually end up. So we're gonna talk about head-to-toe assessment. The idea of this is, you don't wanna miss something, right? So when you're doing that triage, that's real quick. Are they breathing? If not, you know, try to open the airway once. If that doesn't work, try one more time. If that still doesn't open the airway, sorry, black tag, on to the next person. Severe bleeding, you're gonna treat that. Or a shock, you're gonna treat that, but nothing else, right? So now, you got them out here with our red and yellow and green parts. They're out here, we're gonna take a better look at them, head to toe. And see just, you know, how serious is it? So they might be there in yellow, and as you go through this head to toe thing, you find out, oh, there's something going on here we didn't realize. They didn't notice some severe bleeding. And figure out what kind of treatment they're needed, and document. So everybody who becomes an EMT learns DCAP BTLS. So if you ever think you might want to become an EMT, here's where you can really get a head start on some of the annoying memorization. DCAP BTLS is deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. And the punctures can also be penetrating injuries as well, punctures or penetrating. So deformities, so this guy probably has a broken arm. Now, not being doctors, we can't say this guy has a broken arm. We don't know for sure, but what we can say is he's got an obvious deformity of the arm. And that might be the way we write it down here, for obvious deformity, right forward. So anything that's just, you know, out of place, well, that's contusion is just a fancy name for bruise, right? This guy's got a contusion, he looks like he got punched in the eye, although getting punched in the nose, as some of you may know, can also give you black eyes. But bruise, basically contusion is a bruise. Abrasion, that's the road rash we talked about earlier, right? Punctures and penetration, something has gone into the body. That something might still be there. And I think they'll say this later, but I will go ahead and say right now, when somebody has something stuck in their body, never, ever, ever, never pull it out. Don't remove it, right? You're gonna just secure it in place. Now, sometimes they get something stuck in them that is attached to a fence or a building or something, and then if at all possible, you wanna cut that thing off, like they're stuck in the top of a fence post or something. Cut that off so that it stays in there, and then tape it up, pad it so that it stays as still as possible. Because what do you think is gonna happen if you pull it out? It's gonna start bleeding. Yeah, they might bleed like crazy.
Rest.
That might kill
When you open the room,
make
it worse.
Leave penetrating objects in place. Penetrating objects in the eyes, I know that sounds horrible. You need to close both eyes, cover up both eyes, because if you leave one eye open, as they look around with this eye, the eye with the penetrating thing in it is going to move around too. So again, tape it up, pad it, try and keep it from moving and cover it. Burns.
Nick, can I add one thing to that? Something that you want to be considerate of too, with that eye penetration, it's a situation that just occurred, right? Now this person has something impaled in their eye and they can no longer see. How do you think that's going to affect them mentally, psychologically?
Not well.
Exactly. So outside of just the penetrating object, we now have a definitely psychological addition to this. So you really, all of them, but this one too, you definitely really want to pay attention to that one. Thank you, Nick.
Well, by the way, in the video, with that distraught bus driver, the firefighter told her to relax. I am not a fan of telling people to relax. Has anybody ever relaxed because they were told to relax? I don't think so. Yes?
I panicked because of it.
All the
They
time.
said they panicked because of it. Yeah. It does sometimes backfire, and let me explain why that is. And this will just be a little hint of some of the stuff is psychological first aid. What really traumatizes us is when we're helpless to do anything about the situation. It's very much about control. When people feel like they have no control, so you can't see, you have no control. So of course, yeah, you have a very strong psychological reaction to that. So now in public safety, we're all action-oriented, problem-solving people. So we just want to solve the problem. So by telling you to relax, I think I'm solving the problem because I'm commanding you to relax. Who's got control at that point? I do, right? You're gonna make the person feel more helpless if you try to control their emotions. So I'll tell you what I say to virtually every person I meet who's had an accident, an injury or something. And seriously, I say this almost every time. I say, wow, but this isn't what you were planning to do today, huh? Right? That just acknowledges, and I'll say stuff like, hey, this really sucks. This is really rough. It is way more powerful, way more relaxing to people to acknowledge that what they're going through is horrible than to try to control it, because you can't control it. Really, you make it worse when you try to control it. So this is going to sound strange, but in a sense, never try to make people feel better. You can't. You can't make them feel better. They're going to feel what they're going to feel. They're just going to feel like they have even less control if you're telling them to calm down or settle down. But you can tell what you can do is invite them to take a few deep breaths and just real strong acknowledgement that, hey, yeah, this is scary. With little kids, I'll just say, hey, this is really scary, isn't it? We're going to take care of you. We're all here to help you. And just reassurance is good, right? Reassurance is fine. We're going to take really good care of you. We're doing everything we can. Don't make promises you can't keep. Although, actually, I make exceptions for that with little kids. I will tell little kids, you're going to be all right. We're going to be here for you. Parents will ask me, should I promise my kids I will always be here for you? Yes, right? Because as they get older, they will understand that was your intention. Right? But with adults, just be real, right? All right, go, we have fun. Burns. I've dealt with a few of those. I was driving a burn patient to the hospital a couple of nights ago, 3 nights ago. Because the fire kind of jumped up on one of our things. We are going to talk about how to treat burns. Tenderness. And that's especially around the chest and belly and so forth, but other parts of the body too. So this is where, as you can see, the hands are actually on there. You may be actually palpating, fancy medical word for touching, and saying, does that hurt, does that hurt, does that hurt? And you want to notice where. Lacerations, fancy name for cuts, right? Sometimes abbreviated just black. And then swelling. Right? They're showing that this guy got whacked in the head by something. You tend to really get a lot of swelling when you get hit in the head because your head has lots and lots of blood vessels. People bleed like crazy from wounds in the head. They look horrible, and it might look like the person's going to bleed to death, but usually it stops bleeding very fast. They're usually not nearly as bad as they look. And the reason your head has all these blood vessels is because your brain is very sensitive to temperature. And so that's to regulate the temperature of your brain.
I think that there's no swelling and it's just like mushy because
that's not good. If you've got a head injury and it's mushy, yeah, I mean, I've certainly had people in car accidents where I'm holding their cervical spine, holding their head straight, and it feels crunchy here. Those people usually don't live. Because they've got skull fractures, they've got bad skull fractures. So you want to be careful, be gentle, don't be pressing on that.
Yeah.
All right. So the damage here is if these people are in a structure, right? So if they're in a building with light damage, and we'll talk more about how to determine that. You can do this assessment right there. You don't actually have to take them to the treatment area. If it's moderate damage, then you want to move it, get out of there, move them to the treatment area. If it's severe damage, you shouldn't be in there with them, sadly, because that building is too dangerous for you to go into. So assess, tag everybody, and that means both talking to them and actually physically examine them. So head to toe, pay attention, look, listen, feel again. So check your own hands for patient bleeding. So what that means is, for places you can't see, you're going to put on gloves, of course, goggles, mask, helmet. This person's lying on their back. You want to know if there's bleeding back here in the flanks? You take that gloved hand, slide it in there, feel around, pull it up, look at it. If your hand is covered with blood, your glove is covered with blood, you know you've got some bleeding back there. Right? Pretty simple. So just these places you can't see without having to move the person, you just slide your hands in and then look at the glove and see if you've got blood. So if you think a person might have a spinal injury, and why would you think somebody might have a spinal injury? What would be the clue to that?
Because they can't move.
Well, let's say they're unconscious. Like it says here, they're unconscious.
Their back is bent out of shape?
Yeah, if their back's bent out of shape, that's a deformity, that's a pretty good clue. What else? What otherwise?
They're just, you feel me?
Just what?
They're just like, if that makes sense.
Limp.
You can't make that problem.
You know what I mean? No. Nah. Not following. Somebody translate?
They're like curled up, what you mean, like? They're chilling, like they can't move, like they don't work no more though.
They're unconscious. Oh, you mean their whole body's like that?
Yeah, like that whole body turns shriveled up and shit, you know what I'm saying?
Yeah, so that might mean that. But
Swelling,
I want you to think about it in a different way.
Jeopardy,
It's what we call mechanism of injury. You'll hear this a lot if you keep learning this stuff. Mechanism of injury, which is how they get hurt, right? So
MOI.
So you arrive, here's a step ladder, and there's a wall that's half painted, and here's this guy on the ground. Mechanism of injury, he fell off the ladder. Well, if he fell, 15 feet, pretty good chance he's got a spinal cord injury, right? You're driving down the freeway, and here's a car crash, and you decide to be, the good person and stop and help, and these cars are just smashed, really, really badly. Mechanism of injury says, yeah, they probably got neck injuries, just because of the amount of damage to the vehicles. Car went down a hill, or a person rolled down a hill, and there's rocks everywhere. Pretty good chance they got spinal cord injury, right? So this mechanism of injury is really how we decide whether to try to immobilize the spine or not, much more than what symptoms the person actually has. If they do have numbness, tingling, they can't move, that's really, those are real good signs. But even when they don't have that, so we had a person in fire camp who stood up real fast, putting some recycling into a dumpster, and there was a big metal bar, and one of the other people nearby said it sounded like a big bell ring, and she just whacked her head against this, she's stepping up on some steps. And the paramedic who we had working in camp decided we're going to put a cervical collar on her to immobilize her head, and we drove her to the hospital just to make sure she was fine. But just because, again, the mechanism of injury. So learn that phrase, mechanism of injury. So check PMS in all extremities. So PMS stands for other things as well, but here, what it means is pulse, right? Motor, meaning I can move, and sensation, which means I can feel touch, right? So you might make sure that, and remember the finger thing, the perfusion check, you can do that. The P could be perfusion. That's actually a better word for it. So, toes, fingers, and so forth. Can they wiggle them? Can they feel if you touch gently? And do they have good perfusion? You want to check that. And if they don't have good perfusion in one of the extremities, or they can't move things, or they don't feel it when you touch them, they probably have some kind of spinal cord injury or something's going on there. Look for medical identification. What kind of thing would we be talking about there?
Like medical bracelets?
Yep.
Medical bracelet, which would tell us what kinds of things.
Necklace.
Like shoe ID tags.
Well, I don't know.
We're looking more for things that might affect how we treat them.
Maybe it's diabetic.
Diabetic.
Yep.
Seizure disorder. Any number of things that might give you an idea of, and it's not just for you, but it's something you can write down. Remember, you're documenting everything. Wearing medical bracelet in case like that bracelet gets lost along the way. you know, it's very useful to the hospital to know, yeah, this person has diabetes, or this person has a seizure disorder, or whatever it might be. Tell, we go head to toe. Pretty simple, right? So start with the head, neck, shoulders, chest, arms, one at a time, abdomen, which is the belly, pelvis, you want to look and see if the hips are intact or broken, whatever, and then each of the legs. And there's going to be a video that will show this in more detail. So, if the mechanism of injury or their symptoms suggests that they might have a head injury, and by the way, anytime somebody, one of the other clues that there could be a cervical spine is this part here, your neck. One of the clues of a C-spine injury is a head injury, right? If they hit their head really hard, they probably also could have damaged the cervical spine here. So, if they have a head injury, if there's some reason you think that their neck or the whole backbone, the whole spine might be injured, you want to keep all this in a straight line as possible, and you want to keep their head stabilized. So I think this is something you will practice on Skills Day. Yeah. But we do this all the time, especially in car accidents and things where we get the person laying out flat, and then somebody, often me, will be usually kneeling at the person's head with just cradling their head like this, keep it in a straight line, slight pressure toward, be pulling very, very slightly toward you to keep everything nice and straight. And then every time we need to move that patient somewhere, that person holding the head's in charge. Like I'm going to roll them over to see if they have injuries underneath. I'll move with them, and the person at the head is always in charge. So I'll say, roll to the right on 3. 1, 2, 3. Everybody goes. Anytime we're going to pick them up, moving, anything like that, that person holding the head just goes with them. Yes?
You know how it says like keep spine in a straight line? What about person that has
You keep it as straight as you can. You're not going to be able to straighten it because it's all else's, so but you still want to keep everything aligned. And I think what you'll discover then is, as you try to straighten it out, it will only straighten so much, and that's where you're focused. Any other questions, comments? Burns, thorough size up, first aid. So we want to cool the burned area. We used to say lots and lots and lots and lots of cold water, and then we discovered we were getting people too cold. So enough cold water to stop the burn, right? We don't put anything on burns. What we want is a dry, sterile dressing. And we want to, these days on the wildland fires, any burn bigger than about a quarter, we're sending them to a clinic. And then when burns get much bigger than that, they send them onto a burn center. Okay, so burns is there. So how hot the thing is that burned them makes a big difference. For how long they were in the burn stuff. So let me tell you about one of the dangers of wildland fire. It's called ash pits or stump holes. What happens is a tree will burn, or it'll be a stump that'll burn, and it'll burn down into the ground, and then that hole where the roots used to be is now just ash, and it can smolder down in there for weeks, and it can look just like the rest of the ground. So a firefighter can be walking along, and all of a sudden, boom, the leg goes down into this, and it can be hundreds and hundreds of degrees down in there. And the longer they're down in there, the more you're going to get burned. And we see this way too often. So we teach them actually to take their tools and, poke where there might be ash pits to avoid stepping into them, because it's really hard to get yourself back out once you're in there. You can get severe burns really fast. Kind of like that, but right here, just above the boot. So how hot it is down there, how long their leg or legs stay down in there, and then what area is affected. So let's see what the next slide says. Okay, area affected. So burns to the hands, especially the palms of the hands, soles of the feet, anything around the face, neck. These are all real high priority. The palms of your hands, soles of your feet, they don't get good circulation from the blood, and you don't want scar tissue to form there, because then you can't use your hands and feet. You need those, it's real important. Anything around your airway, we'll talk more about this. You can get swelling, and especially if people inhale hot gases, that swelling can cut off their airway and they can die. just from the swelling that can happen. So anything around the face and the neck, immediately high priority. Whether they've inhaled hot gases or not, just assume it. Burns to the genitals, sounds awful, but that happens to me, but that's also real high priority. And the size of the area burned, we have some formulas to calculate, it's called rule of nines, because there's different areas of the body are all 9%. But the bigger the burn is, the worse it is, of course, and the depth of the burn. We used to say first, second, and third. We still do a lot of the time, but the preferred language now is superficial. So that's where your skin's just red, right? Like a sunburn. A sunburn is a superficial burn. Partial thickness. Now let's get into that second layer of skin. You're likely to have blisters, as you can see there. And then full thickness is getting down even deeper to where there's fat and that sort of thing. Another kind of burn, by the way, that is very high priority is a burn, we call it a circumferential burn. A burn that, so when firefighters step in those ash pits, and I'll tell you, I'm thinking about this because we had a guy who did this a few weeks ago in our fire. If it goes all the way around part of the body, all the way around the leg, all the way around the arm, all the way around the abdomen or chest, that's a big emergency. Partly because as the body reacts to it, it can start tightening everything up and cutting off blood, and turning to, you have a lot of complications above and beyond just the burn itself. So, cool skin or clothing if they're still hot. So this is where we want to use lots of water. It may take more water than you think to really cool it down to stop all the burning and everything. And then no ointments, no creams, nothing. You only put those kinds of things on the tiniest little burns. If it's, again, the size of a quarter or bigger, cover it with a loose, dry, sterile dressing. You want to keep the air out. That's going to help with pain, stop infection. The elevation again. The elevation stuff we used to teach a lot. It doesn't really seem to make that big of a difference. Don't use ice, definitely. We've had people get frostbite right after they got burned. And frostbite destroys tissue just as badly as burning does, so that's not good. So again, no, don't put anything on a big burn. Don't, just get it cool, dry, or in some sort of dry dressing on it. That's it. Don't break the blisters. Don't try to remove tissue. Don't try to, if there's clothing or anything stuck in there, don't try to remove it. They'll do all that stuff at the burn center, and they're the experts at it. If nothing else, it's gonna hurt if you do that. Chemical burns. So now you have this. Oh, talks about removing jewelry, and yeah, if you can, without sometimes you want to get rid of constricting jewelry and that sort of thing. Just because there's going to be swelling, but not if that area right there is burned again. Look at what I'm saying there. So the thing with chemical burns, you actually want to, if the chemical is on anything like jewelry or clothes, you want to just get rid of those. Now, you're going to want to wear your PPEs because you don't want to get that chemical on you. You should always wear your PPEs anyway, but especially with something like this. So if it's something dry, you get a brush and you just brush it away. And just brush it off to the side and then treat that as hazardous material. Brush away from the patient's eyes, away from you, and then flush lots and lots of cool running water to wash whatever that chemical is away. And in this case, for chemical burns, you can use cool wet compresses. You don't have to stick with the dry dressing to relieve pain. But then again, go back to covering it with clean dry dressing. And then for all burn patients, just like every other patient, if you're starting to see signs of shock, they're breathing fast, they're starting to seem a little bit confused, they don't have good perfusion, you want to treat them for shock, which means keeping them warm, and get them to the hospital ASAP. So inhalation burn. So if you think there's any chance the person has inhaled hot gases, this is a big emergency. So you look in their mouth, you look in their nose, and if you see soot, you see it looks like the hair has been burned or they've got soot in their mouth. This is a person who needs to get to a hospital or get advanced life support right now. I mean, big, super critical emergency. And if they're passing out, it's probably because they can't breathe because they've got swelling in the airway. And that's no fun. And of course, if they, as I said before, burns around the face and neck, you want to suspect this. All right, that's burns. Wound care. So first, control bleeding. So we talked about that before during triage. If it's severe bleeding, you want to control it right away. If it's not, if it's just oozing out and it's not too bad, once you start doing the full treatment, now you want to go ahead and treat that minor bleeding. That might not be as big a deal. So you want to clean that. Remember what I said about how we clean it. Clean water, spray with a gentle stream of clean water. That's really the only kind of cleaning that you're qualified to do. That's all I'm really qualified to do as well. And then you're going to put a dressing. So a dressing is something like a 4x4. So you'd want this to be sterile. So this would be in its paper container. And you'd be wearing gloves, which would be clean. And just try not to touch the part that's going to go against the wound, so that you're putting the clean side of it on the wound. And then you'll hold the dressing in place with a bandage. So this is rolled up, and you could go around, if it's an arm, leg, abdomen, whatever, you go around and use this, not too tightly, to hold that in place. If they're bleeding a lot, you might want to use a lot of those. Once you put that dressing on there, never, ever, ever pull it back off. Because what's going to happen? Yeah, it's going to rip it open. The person's going to bleed more than they would have otherwise. So what do you imagine you do if the blood keeps soaking through?
Add more.
Add more.
Good job.
That's it. You're just going to add more dressings, and then rebandage it with more dressings in place. But never, ever, ever pull it off to look at it or do anything, because you're just going to undo all the natural clotting that's stopping the bleeding. I guess I got ahead of that. So clean, room temperature water. Don't use peroxide or anything else, just clean water. And irrigate, meaning gentle stream, try to wash anything out of there. And then the dressing and bandage. So I guess I should have just gone forward with the slides, because I was going to say what I was just saying. So now, hours later, the next day or something, if the bleeding has stopped for a while, then you can take the bandage off and put a new clean one on. And you want to check for infection. So everybody know what the signs of infection of a wound would be? Pus coming out of it, absolutely an indication of infection. Even before that, you'll start to get redness around it, right? So, if the skin around it is starting to get red, and you get swelling and so forth, those are signs that it probably became infected, so it needs an antibiotic. Maybe a trip to the clinic, the doctor, yeah.
Type of red, meaning like rash red or like irritation?
Just like sunburn red, that kind of red. And if you see redness that's starting to travel like toward their heart, this is not a good sign. This is a sign the infection is getting into the bloodstream, and then that can head toward what's called sepsis. Sepsis kills people, right? And if sepsis gets established, it's an infection in the bloodstream. That can be extremely lethal. Even people who survive it very often don't live for a long time, maybe a few years afterwards, end up having a lot of organ damage and so forth. It's real serious stuff. So you really want to catch infection early on, because it can wind up, it can sometimes actually literally take years, but it can end up killing people. Oh, there we go. That's what infection looks like. There's the redness, the swelling, discoloration, discharge from the wound. There's the pus. And the striations, the stripes, that's where that infection is spreading, and it becomes pretty urgent to stop it. Amputation. So this is an arm or leg that has been cut off completely. If you find that part, you want to wrap that body part in clean materials. You want to put it in a plastic bag, and you want to put it on ice, but not directly on ice, because you can give that amputated part frostbite, right? So you want to wrap clothing around it, or a towel, or some paper towel, something, so it's not directly in contact with that ice, but keep it cool. And then make sure that that body part stays with the person so they can be infected. It is astonishing what they can do these days with microsurgery and so forth. I guess it's been a while now, you guys probably wouldn't remember it, but we had a little girl who was, maybe 7 or something, in Los Gatos who was in a minivan playing with a jump rope. She had it wrapped around her wrist, and the jump rope went out and wrapped around the wheel of the car and it cut her hand. And they got her to Stanford Hospital very quickly. They reattached that hand and she's able to use it. Just pretty amazing what they can do these days. Made the news all over the place. It's pretty hard to look at.
How does that work though? Because with the bone and everything.
Got me. That's pretty astonishing. It's microsurgery where they're using microscopes to reattach the nerves and bones. And, it blows my mind that they're able to do it.
Yeah,
It used to
open
be
up
like
a
when I was
plate or
studying,
something.
if a nerve got cut, there was no repair. They had no idea how to get the nerves to reconnect. But these days they can do it. And amputations, controlling bleeding. This is where you very well might need a tourniquet, but you don't necessarily always need a tourniquet with an amputation. So our blood vessels, when they're cut cleanly, they're like rubber bands and they'll snap shut, right? So you can actually, somebody gets a really clean amputation, it may not bleed much. You may not need something like a tourniquet. But an amputation, just like with everything else, first thing to try is direct pressure, and then if direct pressure doesn't work, then you go to a tourniquet. Impaled objects, so I mentioned this before just because it's so important. Immobilize that part of the person's body and the thing that's sticking in them, whether it's a knife or a fence post or whatever it might be. Don't try moving it, don't try to remove it. Stop the bleeding where it went in, of course. You want to try and clean all around there as much as you can and stabilize that object. Sometimes we'll take small pillows and put those around it and tape everything in place just to try to keep that perfectly still relative to the person. Fractures, dislocations, sprains, and strains. These are all going to look about the same to you, without x-rays and so forth. You really can't tell if we're dealing with broken bone, which is what a fracture is. A dislocation where something's come apart. I horribly dislocated my shoulder a few years ago. There wasn't much question that it was dislocated. And then sprains and strains. We had a guy on the last fire I was on who was using a pallet jack, which is a manual way to move pallets around in the food service unit. And somehow it went this way and he held onto it and regretted holding onto it because he kind of just strained and tore all sorts of ligaments and things in his elbow. And so he came to us just in horrendous pain. It really hurts.
Did you get workers' comp?
Oh yeah, everybody at fire is covered by workers' comp. Workers' comp or the agency itself. That's required. And it happened on the job. And by the way, that pledge you just did as a disaster service worker, when you're activated under that disaster service worker, you're covered by California State Workers' Comp law. That's a lot of what that's about. It's not as wonderful as you might think, though. I mean, it's great that when it's an obvious injury that happened, it's pretty easy to get treated and so forth. When it's other things, sometimes that are more subtle, it can be a fight with them to get covered. But, it's better than not having it. So, if you're not sure if something is a strain, a fracture, dislocation, whatever, treat it as if it's a fracture. So, a closed fracture is the skin is intact, there's no bleeding or anything. We might have a big bruise. I mean, I have a horrible bruising from my dislocated shoulder, but there's no opening in the skin. An open fracture, also sometimes called a compound fracture, there's a wound where it's bleeding and so forth, and the bone's broken, and the bone might be sticking out of that. It's just, that's fun. So, at the hospital, they will try to put everything back in place. You don't ever do that, right? At the level of CERT. You don't want to try and clean it. You just want to cover it with a dressing, and you want to splint it exactly as it is. So we did bring some splinting materials and so forth. I think we'll probably play with this stuff on Skills Day rather than today.
Yeah.
But this is a generic version of something called a SAM splint. And it has wire inside here that lets you bend it and it'll stay however you want. So there's a few different ways to use it. You can bend it this way, and then it becomes fairly rigid. Put it up here, by the way, what we usually like to do, or if somebody's got it in their hand, we'll make a, this is part of the reason, essentially, roll something up here so they can actually grab it in their hand, just the way that they will feel comfortable grabbing it. So you put the splint on like this, and then again, take this stuff and go round and round and round, not tightly, just to hold this in place. And the idea is you're gonna keep everything still. So especially with an open fracture, you're not gonna worry about getting it into a position that's comfortable for them. Don't do that, you may make things worse. As you move them around, you may cause the broken ends of the bone to cut them, and the bleeding will get worse, and it'll hurt a lot, and it'll just be a bad day for everybody. So just figure out how to use this and your other stuff, and maybe pillows and blankets and whatever you got, to immobilize it exactly the way you found it, and get it to stay still, because it'll hurt if you move it around. If you got the bone end showing, you want to put a voice dressing over there. Displaced and non-displaced fractures. So if it's not displaced, it's just a crack in the bone, but the bone is still lined up exactly the way it should be. But sometimes the displaced fracture means that now you'll be able to see there'll be an obvious deformity in the limb, wherever it is, and you'll be able to see that this doesn't look right. It's displaced. So dislocation is where the bone comes out of its socket, or really common dislocations are shoulders and knees. Dislocated knee hurts a lot, I'm told. And dislocated elbows, which is what we thought that guy had, I'm told are super, super painful. Turned out his wasn't actually dislocated, what he did. But he did say, the doctor told him 7 or 8 weeks to recover from just all the strain and sprain that he took. Basically, it pops out. So the way I did mine was bicycling home I was working in Mountain View, and was riding bicycle around the runways at Moffett Field. Had really good tailwinds, and I remember thinking, let's see how fast I can go, and going real fast down this trail, and there's a pothole, and over the handlebars, and landed on this shoulder, and my helmet, thank goodness that's where they didn't get that bone back into the socket until about 5 o'clock the next morning, and this happened at 7 in the evening, 6 or 7 in the evening. So I went for a very long time and got some very, very good drugs to get through that. But so sometimes the longer it takes to get the person to the hospital, the harder it's going to be to get that back in. Yeah.
My mom told me about this time she was riding her bike and she fell off and her helmet broke, but her head stayed intact. So that's all it was like.
Yeah, and by the way, if you ever are dealing with a bicyclist or a motorcyclist who is wearing a helmet in an accident, that helmet needs to go to the hospital with them, so that the hospital can see what the damage to the helmet to get an idea of the mechanism of injury. So they have an idea of how well did this helmet actually protect the person. So I had my bike helmet with me when I got to Stanford Trauma Center, and they could see all the scratches, but they could see it wasn't cracked or broken. Your mom, if her helmet broke, probably wasn't quite as well off as I was, but it sounds like the helmet's safe. So, for dislocation, you want to immobilize it again ideally in a position of comfort. It can be really painful to move it. Basically, after I dislocated my shoulder, I had to hold my arm like this. If I tried to go in like this, I was screaming in pain. So they stuck a pillow in here, put a sling here, and then put a swath, which is just a bandage that goes around my chest, but kind of hold it in place. And that was okay. Although it was way more okay when they gave me Galali, which is almost heroin, I'm told. And then they ended up giving me ketamine to actually knock me out enough to be able to get the bone back in place. So Colin brought me triangular bandages. I didn't realize that's what you said. So with these, you can do it a lot of different things. These are just really handy. One of my mentors suggested just buying a nice bed sheet, and then you can tear or cut it up to make these or almost anything else you want. But you can tie a knot in one end, and then it becomes a nice shoulder sling with the elbow going where the knot is. Or you can kind of wrap it up like this and do I talked about the swath, I can't really do that to myself. But you just, put it around the arm, all the way around here. But these are just, you'll find triangular bandages in most first aid kits, and they're just real handy for basically another way to attach the person to the splint, or hold an arm up, hold an arm against the chest. Okay, so to treat, as said before, don't try to figure out if it's a fracture, a strain, a sprain, a dislocation. Just for all of it, if you're not sure, treat it like it's a fracture and immobilize it. Don't try to put things back where they belong, way out of your skill range. And remember PMS, perfusion, say movement or motor, and sensory. So let's say you got the dislocated shoulder. Before you put the sling and swath on, you're gonna check perfusion, the real fingernail thing, right? You're gonna say wiggle your fingers, wiggle the fingers. You're gonna touch them lightly, say, ask if you can feel that, they can feel it. Now you're gonna do all that, right? Sling, swath, splint, whatever. Get all that in place, then you're gonna do it all again, right? So check perfusion. Oh, look, it's taking more than 2 seconds now. What do you need to do? Or they can't wiggle their fingers. Or when you touch them, they don't feel it. What would you do if that happens? Loosen it up. So it's too tight, right? If you, or maybe you need to actually move their arm, leg, whatever, because something has cut off blood flow or it's cut off the nerves. Now, swelling can do that a little bit, but it's not going to cut it off completely. But you need to move it around a little or loosen up. Maybe you got something too tight. But we don't want to put things in a position where we cut off blood flow or cut off the nerves and so forth, because that's just not good for your patient. So check PMS before and after splinting. So on skills day, when you practice this, you're going to practice that. So you're going to say, you're going to check perfusion. You're going to say wiggle your fingers, wiggle your toes, whatever. And then touch them and ask them if they can feel that before and after splint. Signs of sprain, we get these all the time, of course, on fires and other places. So it's going to be tender, you can see bruising and so forth. They might still be able to walk on it. If it's broken, they're not going to be able to walk on it, guaranteed. But with a sprain or strain, they might be able to walk on it, but it's going to hurt, and they're not going to want to walk on it. And you might see the bruising. So there's splinting a leg. Cardboard boxes are great. And Amazon boxes, which we all have lots of, you just throw some of those in your car because, especially the sort of medium-sized ones there, which is like the perfect size to make a lot of these things. And you can even, sometimes if the person injures their knee, you'll need to splint it like this with your leg bent. So you put the corner of the box right there. So just imagine if this was cut right here so that we can bend, and you'd be able to splint, make up even a bent knee splint. Shipping boxes are great for that. Notice that it's folded over on the end to hold it on the end here. And I guess there's padding?
Yeah. Yep.
So that's padding really for the other leg. Sometimes you can splint people's legs together because one finger can act as a splint for the other finger, one leg can act as a splint for the other leg. But especially with something as big as a leg, you want to keep it stiffer maybe than the other leg is going to make it. So here, a roll-up blanket can work really well. And even rolled up magazines, newspapers, be creative. Derek mentioned the wilderness first responder class. They teach you, I think he mentioned, they teach you to make splints and so forth from all sorts of materials. Especially stuff you might have with you on a backpacking trip or something like that. Or if you're working on a trail somewhere and you need to splint something, be creative and try to mobilize it. And remember that immobilizing it, holding it still is going to make the person feel a lot better because it's really the movement that hurts, not the break itself. And you're going to keep it from getting worse. And especially if you then have to move them, you really don't want to try to move somebody without first splinting something that might be a fracture, dislocation, or whatever, because it's gonna hurt. So whenever you splint, you need to support the area above and below the injury. So that includes the joints above and below. So if I've got a possible broken arm here, I need to immobilize this joint and this joint, right? So the splint needs to go across all of them. If it's up here, you need to immobilize this joint and this joint, right? So always the joint above and below the area around. Again, check that PMS. Splint it in the position you found it. Now, on a practical basis, if the person is able to move it around, and you say just find the position you find most comfortable, and then splint it that way. But if they can't move it around, they don't want to move it around, just splint it as you found it. Don't ever try to fix anything here. That's very specialized skill. Fill voids. I've mentioned pillows a bunch of times. So pillows or anything like pillows to fill in spaces. That way it can't move so much. Especially if you have to carry somebody. You really want to fill in all those voids and get everything really stable. Support the injury area above and below. Immobilize above and below. I'm not sure what the difference is. There must be some difference there, but it's really kind of redundant. And then remember, again, keep emphasizing this, PMS before, PMS after. And where that's super important is if you ever find yourself in a situation like where somebody is way out in the woods and you have to hike them for an hour or two, you really want to make sure you didn't cut off blood flow or the nerves or whatever. Nasal injuries. So anybody ever been punched in the nose? Ow. Anybody ever walk into a closed glass door that was so clean you couldn't see it there? I was in a television studio one night. Well, I was in there, we were producing a little video. We were in there the night before, and then the cleaning people came through in the middle of the night sometime and closed this brand new, perfectly clean glass door. Walked in there the next morning without turning on all the lights and just boom, right into it. Did I break the door? Or my nose? Did not break the door. Didn't break my nose, but boy, I had to sit down for a while. Okay, so sometimes that's from trauma, from getting smacked, or hitting the steering wheel, airbag going off, something like that. But there's other things too. So sinus infections, high blood pressure. If somebody keeps getting nosebleeds, they may have high blood pressure. That can be a sign of it. So they need to see a doctor, figure out if that's what's going on. Some people do have bleeding disorders where the blood just doesn't clot very well, and so they might have frequent nosebleeds as well. So it is possible to bleed so much from your nose that you start going into shock. Yes.
What about it's too hot though? Like people get like their body temperature and maybe you start bleeding from their nose?
So when it's hot and people get nosebleeds, that's usually because it's so dry outside. And we see that a lot on fires. We started, as the humidity dropped really low on this last fire I was on, and actually every fire. We have 4 or 5 really dry days in a row, and people start coming in with nosebleeds because it's really the dryness, not the heat. But it could be some of these other things as well. And you may not realize how much blood you're really losing because they may be swallowing some of it, which is not good because that'll also tend to make them nauseated, and then they're throwing up. And then they're throwing up blood, you don't know if that's coming from here or here, and it's like, let's get this person to the hospital. Pinching nostrils or pressure on the upper lip under the nose. That one I don't think I've ever really used. And so you want people to sit with their head forward. Some people think they should sit with their head back. Well, then the blood is going to drain down their throat, make them nauseous, and then be thrown up, and like that. So it's leaning forward, pinching, and help them stay calm. So, and you just, all you can really do is keep trying this, and sometimes for like 10 minutes. And if it just won't stop, you got to get them to a clinic or a hospital or something. I do know some other things you can try, but they're really not level things. So if it just won't stop bleeding, bear in mind that you can lose enough blood through your nose for it to be a real emergency and get at least urgent care, if not an emergency. All right, hypothermia. That's when you get chilled too much, and your core body temperature like deep down inside starts to drop. Normally, the temperature deep inside your body is very, very, very stable, even though your skin may get cold. Hypothermia is when the cold starts really working its way in. And then frostbite is where you're exposed. Usually it's like tip of your nose, ears, your toes, fingers, actually completely freeze. And that will kill that tissue just like burning will. So hypothermia, body temperature gets down to 95 or lower. And that's only a couple degrees below normal, because normal these days really is around 97.5 degrees or so. So it really doesn't take much of a drop in temperature at all for you to go into hypothermia. Skin can be red or blue, and shivering, although one of the things we know is that as long as you're shivering, you can warm back up on your own.
That's what shivering is for.
When the shivering stops, now you're definitely getting into trouble, right? Remember what I said about altered mental state. So slurred speech is one of those things that says, okay, this person's brain isn't working quite right. And anytime you get an indication of this altered mental state, where they're confused, slurred speech, any of that stuff, now you know you've got an emergency on your hands. For some reason, their brain is not getting enough oxygen or sugars, and that's life-threatening. Unpredictable behavior, again, the brain, right? Listlessness, again, the brain. All those are signs that the brain is not quite working like it normally should. So, get them out of the wet clothing, get them in a blanket, protect them from the weather. If people are conscious and able to swallow effectively, it is okay to give them food and drink. So one of the things I tell firefighters on cold days, and even though we're fighting forest fires, we had fires going until the middle of November last year. I was in the Sequoia National Forest. In the middle of November last year, we were flying some of my medical folks up to 9,000 feet where the fire was in the middle of November. In fact, we couldn't land a helicopter up there for a while because there was snow on the ground, and the helicopter needed these special pads to land in snow. And it was getting down to like single-digit temperatures on a forest fire. Normally we're dealing with too much heat, but we had cold too. And what I was telling our firefighters at briefing is, calories are your friend. Like in cold weather, you need calories, sugar, starches, so forth, because your body's going to burn those calories to stay warm. You need more calories when it's warm, because they're working hard like they always do, right? And that's burning calories, but you need even more calories to generate the heat to stay warm in real cold temperatures. So that food and drink is treatment for hypothermia. But never, ever, 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 ever give somebody food and drink if they're not awake and alert enough to be able to swallow well. Otherwise, they may choke, they may aspirate, they may aspirate fluid into their lungs, and now you have a much bigger problem. Massage is not a good idea, especially if you think there's any chance they have frostbite. Don't massage that tissue, you will make it worse. Put them in a recovery position. We haven't really talked about that, but I think on skills day you'll practice the recovery position, which is on their side, knees bent, ideally on their left side. And you can put them in a warm bath again to get that temperature back. So frostbite, skin gets discolored. It might turn red and blistered like this. It can also turn black. You might feel like it's burning or tingling, and it might be quite numb. So for frostbite, you can put it in warm water to slowly warm it up, but never, ever, ever warm up suspected frostbite if you think there's a chance it might freeze again. So if you're out doing winter camping or skiing or something, and you're not absolutely sure you're going to be able to keep this person warm and keep that frostbitten part warm, don't warm it back up. Let it stay frozen, because it's really bad to warm it up and then have it freeze again. That makes it way worse. So probably lose it. So that's not allowed to refreeze. Again, don't massage it to make it worse. And just like with burns, heat-related injuries, boy, do we see this all the time, not only in fires, but the first hot weekend of every summer here in Silicon Valley, in our parks, in trails and so forth. we get all sorts of people having heat problems because they don't realize they're not acclimated to it. It takes a week or two of being out in heat for your body to be able to deal with it real well. And so we get people who go for hikes, they forget to bring water, they don't eat their salty snacks. One of the enemies of heat is the keto diet. Anybody here doing keto? No keto people? So if you start doing that keto diet, you're gonna avoid carbohydrates. And that means you're not gonna be eating potato chips, you're not gonna be eating pretzels, or other salty snacks. So one of the things that we're starting to see on fires is you get firefighters who are doing the keto diet. They don't want to drink Gatorade because that has a tiny bit of sugar in it. And they're not eating the salty snacks, so they're just pounding down lots of water. Well, what happens is they end up washing all the sodium out of their body, and they regain trouble and other electrolytes as well. Yes.
Is that a reason why like lemonade is healthier?
Lemonade doesn't really have electrolytes in it, but Gatorade does. And then there's Drip Drop, which is great stuff. Doesn't taste all that wonderful, but it's got the right combination of a little bit of sugar and all these electrolytes that your body needs that you would normally get from salty snacks and so forth. Yes.
So I went hiking last year, a really long hike, and my mom gave me advice to put salt in my water because if you don't have enough salt, if you feel it, you feel sick.
Absolutely.
So I felt sick for a while because I did not do that. I forgot. So I just ate a bunch of beef jerky because it had salt, and that was what made me feel better. So you really feel like you don't have enough salt.
They were saying the mother advised to put salt in the water. Yeah, I mean, you need salt. You sweat off the salt, you lose it's potassium, sodium, and other electrolytes. Your body runs out of them, things don't work well. So I got kind of a horrifying story about that. There's a firefighter kind of in the East Bay, Vacaville, Fairfield. This guy is a former professional baseball player. During that really hot stretch we had back in June, he's on a keto diet. They had a bunch of calls they responded to. He's drinking lots and lots and lots of water. He went into cardiac arrest on duty. So if you're going to go into cardiac arrest, doing it around some firefighters and paramedics is a really good idea. So he managed to get his heart going again, took him to the hospital. He survived. But at the hospital, they found they could not detect any potassium in his system. This guy's lucky to be alive. But again, because of the keto diet, he's not eating the salty snacks and things that have those electrolytes. He wasn't replacing it with something like, there's Drip Drop, there's Liquid IV, ORS, there's none, that's one of my favorites, you can get at the outdoor shop, that's NUUN. So if you're not getting, if you're not eating things like bananas that have lots of potassium and salty things and so forth, and you're drinking lots of water for the heat, you've got to get those electrolytes some other way, so make sure you do. And if you don't, you will start getting things like this. If you don't drink enough water, you get heat cramps, where your muscles will just start cramping. And then heat exhaustion. Now, neither of these, heat cramps, heat exhaustion, these are not big emergencies. When this happens to firefighters, we put them in the shade, or if there's a vehicle with air conditioning, we'll put them in there, we'll have them drink water slowly, or drink Gatorade, or Drip Drop, or something like that.
It burned down.
So heat exhaustion, people feel nauseous, you might have the muscle cramps, maybe a little lightheaded and dizzy. But they're sweating profusely and feeling very tired, right? But they're still mentally pretty alert. So heat stroke, life-threatening, big emergency, let's get a helicopter in here and get this person to the hospital right away, because you cross a line where your body can no longer regulate its temperature. And this can kill you quickly. So temperature control has shut down, and brain damage and death may result. So what heat stroke looks like is, number one sign is that confusion, right? The altered mental state. So once again, this is why I really emphasize, and I even remind my firefighters and even my EMTs, the paramedics generally kind of understand this, but even EMTs aren't always really attuned to the significance of this altered mental state. When somebody starts acting even a little bit confused, especially if they've got these other things going on, this is call 911, get help right away, real quick, this person's life is in danger. And usually with heat stroke, their skin is red and dry, right? If they're confused, even if their skin isn't red and dry, it's still big emergency. but especially red, dry skin, no longer sweating, mental confusion, big emergency. And then there is one other that I'm gonna mention, even though CERT doesn't, just because we're starting to see it more and more. And it's called rhabdomyolysis, or just for short, rhabdo.
Nice.
Rhabdo happens usually in the heat when people overexert. And this is often not people with little muscles like me, but big, people who really work out a lot and work really
You
hard,
could make them
who overdo it.
on a video.
And
You could make
what happens in
cookies
rhabdo
and
is the body starts sort of digesting muscle, which is really not something you want. And the sign of it is they'll have muscle pain that's like way beyond the normal pain of working hard, and it doesn't go away. Right? Stop doing the exercise, stop doing the work, and the pain is elevated and continues on. And they're either not peeing at all, or when they pee, it's brown and foamy. Again, big emergency. You can lose your kidneys. Rhabdo will destroy your kidneys. You can end up needing a transplant or being on dialysis for the rest of your life. So it's relatively rare, but we are seeing it more and more. I don't know if it's just people are pushing themselves harder in their life, but that's another. So heat exhaustion, we go back. Cool, pale, moist skin. They're still sweating a lot. They might have a headache. They might be throwing up, or feel like they're going to throw up, dizzy, and they're super tired. Not a big emergency, right? Get them into a cool area and give fluids. We take them, for firefighters, when this happens, we just take them off the fire for a day, get their fluids back up, get their electrolytes back up, and they're fine now. Heat stroke. Hot red skin, usually dry, because they're not sweating. Altered mental state, changes in consciousness, big red flag. Rapid weak pulse, rapid shallow breathing, which are signs of what? Rapid breathing, rapid weak pulse are signs of shock, yes. So this is a person who's going into shock. Big emergency, get help right away. So, for both of these, get them out of the heat into a cool environment, cool them down slowly. For heat exhaustion, get them in the vehicle with air conditioning going if possible and cool them right down. Drink water slowly, but again, if they're not fully conscious and able to swallow, don't give them food or drink. And that includes vomiting. If they're having just isolated muscle cramps, I don't know why it says don't give them water if they're cramping, because there's different kinds of cramping. If they're cramping all over, then yeah, we don't hold food or drink. But always remember, with somebody who isn't fully conscious and able to swallow, don't give them any food or water. In general. Bites and stings. If the stinger's in there, you take a credit card and scrape, and it'll come out. That's going to help them feel a bit better. Wash with soap and water. Ice is good. We actually have little pads called stingies that have lidocaine, which is antiseptic in it, a little menthol or something. We put that on, and they work. I got stung by a bee last year for the first time in decades. And so I got to try out one of those, and it actually worked pretty well. But there's this thing called anaphylaxis. And this can happen from a bee sting. It can happen from eating food that you're severely allergic to. It can happen from a snake bite. We have rattlesnakes around here. Rattlesnake bites for adults are not life-threatening. They're not a big emergency, unless anaphylaxis happens. So anaphylaxis is a severe allergic reaction. So you want to see if they're starting to have trouble breathing. Whoop, this is call 911, big emergency, right? Help them stay calm. That will help reduce the body's response to it. Take off any restrictive clothing and jewelry. If they are prescribed, now EpiPen is a brand name for an epinephrine auto-injector. I don't know if any of you guys have allergies where you need to carry epinephrine, but if you don't, this brand is stupidly expensive. I've heard people paying like $350 for one of those. Well, this is the same thing in a different brand, and it cost me $5.
No way.
Insurance. Wow. This is by Mylan. So just a little tip here, if you need to carry an EpiPen, ask your doctor for a prescription for a generic EpiPen so you can get the Mylan one for $5 instead of the EpiPen brand for whatever it is, $50 or whatever sort of affordable price to get people Okay, so we want to watch for signs of shock. So anaphylaxis causes shock by basically breaking down the fluid barriers in the body, so that it's as if you suddenly have bled a tremendous amount all at once, although you're not bleeding, it's just that the blood stops circulating.
Because you less than a mile.
Yeah. I mean, that's not your property, so.
Some people have, there's this thing that some people say that you can like puncture their throat so that they can breathe.
Yeah, I probably is right now until I can get a better one.
The problem is the blood pressure goes.
Later on, see if we can plug in a simplex frequency, see if I can hit you at the house.
Yeah, okay, and then would I need my programming cable?
Okay. You can just plug it in from the phrase of that.
Sweet.
So if somebody starts having, so the big clue is they're having two different signs of allergic reaction. So they're breaking out in hives, maybe, and they're having trouble breathing. Or if they're just having a lot of trouble breathing, that's a sign that they probably need epinephrine. So, call 911 right away and ask them, do you have an EpiPen? And if they do, try and help them use it. Technically, they're supposed to administer it to themselves, kind of beyond your scope of practice to administer this to them, but maybe they'll tell you how to do it. That's as far as we'll go with that. Okay, so we talked about public health concerns around keeping things clean, hygiene, taking clean water and so forth, how we organize, so that's the medical operations. Have the the red, the yellow, and the green treatment areas, and then the morgue somewhere else on site. How to look for DCAP BTLS, which you don't have to memorize, certainly, but if you decide to become an EMT, you will. And then how we treat wounds, fractures, sprains, immobilizing things in place, don't rearrange things, don't try to fix them, and other So, questions, comments?
So, to figure out if there, you know how you said that there's also a system in place? Do we do operations tests in the field, or do we just
Is there gonna be another class like this in the spring or winter?
Is it a wait list for this program now?
Should we get some people in, like, yeah. How often do you have the classes?
We're starting again on October 12th.
That's not bad.
Go to the city.
Yeah.
Put it in. See, once you check it, because the people that was here today,
Yeah.
that lady, she's the actual program manager for the city.
Right.
But she's leaving, unfortunately.
Yeah.
But once you go in and get your name on the list, let me know. Because, and then if it's like hella far away.
Yeah, you like can commute. Yeah. I mean, carpool or something like that.
Do what?
Carpool or something, right?
No, I'm talking about if the date for the class.
Oh, yeah.
Not just call somebody. You know what I mean? Let me get you
I mean, what do you to get the word out about, like, dog safety and all that stuff, and what to do in case, because if dogs are kind of like humans, they're a little bit different now. Especially if it's like a service dog or something like that, and then, gets injured or their owner gets injured, then how do you take care of a service dog?
You mean like lie down on one side? Well, no, I'll lie down. Sure, let's go for it. Okay, so. I'll be on the back. Stand up. Yeah. So when we're coming to this position, the patient's left side is comfortable, right okay. One thing that's really critical to do the left side is with women who are very, very pregnant, it's important to put them on their left side. I'll just explain. The reason left side is better is because if a person throws up, the stomach sort of empties onto the left side. And that's going to make it easier for them to empty the contents of their stomach if they need to. So the way I'm gonna do this is I'm gonna make it a little easier. I would probably put gloves on, but hey, it's cold and that. So I'm gonna help myself by starting off by doing a leg and an arm. And I can tell him what I'm doing, assuming he's conscious. So I'm gonna roll you onto your left side, and I'm gonna hold his head, I'm gonna put one leg over and one arm over. And then with these already in place, I could grab from the shoulder, or I might grab his belt. And if there's somebody helping me, the person at the head is in charge, have I said that? And so I might say, okay, on 3, we're gonna roll on this left side. 1, 2, 3. Sorry? So, you don't want to get that arm on your head. I've done this a long time. So that's what the recovery position is like. Left side, knees up, head on the hand for a little bit of padding. We'll try it.
No, back on the back. So, this arm, the opposite arm, I'm gonna bring it here.
He's right.
This hand here, you want the back of the hand on the, just land like this. Okay? This is Colin's left side. And I can, if possible, I can bend this leg, okay? Come here or here, and I wanna roll him towards me so his body rests on my leg. At this point, I'm here, and look where the hand is. It's already resting on his face. Yeah, or if he's unconscious, and I'm putting him in the recovery position. And what Nick was also saying, a very pregnant woman, and if a person is on the line.
Okay, and then you don't actually do this for real, what I'm showing right now, but this is me putting myself into the recovery position, so you can see the body movements without other people in the way. So I'll put myself in the recovery position on the left side, so my left arm can go straight out like this or up like this. It really doesn't matter, whatever you're comfortable with. And then you would pull my right knee up like that, and take my right hand, put it on my left cheek, grab my right knee, pull me over towards you, and boom, I'm in the recovery position.
And the fact that I couldn't quite remember how to do it should let that be a lesson that it helps to practice this all the time. I'm usually supervising our medics, so I'm not out there doing it as much. And even after I did my EMT in 1975, and you'd think I could, well, we didn't do the recovery position. That was
Yours was still working.
But it's still easy to forget exactly how to do these things if you don't practice them pretty often.
Yeah.
And it's also easy to forget what you do with your mask when you take it off.
And then you also have the recovery role position, and then you have a role when you're checking for the backside, which both, those are two different roles. You're rolling the person, but the techniques are just a little bit different.
Yeah, so with the recovery position, there are several different ways to do it, but they're all very close. You wind up with the same basic ending position. So you can have your arm up, you can have your arm up like this. That doesn't really matter too much. A key thing that I think is to have the hand against the opposite cheek and then roll over like that. So Nick did it by crossing my legs first. Makes it easier to rolling. So that works as well. It's all good. Whatever works for you to put that person into the recovery position. Because rolling somebody who is unconscious is really, really different than you might think if you've never done it before. We have mannequins that are 70 pounds, and when you try to roll a 70-pound mannequin, it's what, half the weight of, or 1/3 of the weight of me, and well, not quite. 1/3 of the weight of me, and it's a challenge to roll that 70-pound mannequin. So when you have a person that's over 100 pounds, you can try to roll them. It takes more effort. Same thing with the head tilt chin lift method. you know, when we did head tilt chin lift method, you're going to be tilting the person's head back to open the airway, right? That's gonna feel a lot heavier than you might think it should be. And that's why we have you do it 2 times, because people who haven't done it before on a real live person, they may not push it far enough the first time. So the second time you're more likely to push farther. And then once you've got that airway open, do we have anything to put under my shoulders? To keep that airway open so you can go off and attend to other survivors, what we'd love to do is raise your shoulders off the ground about 2 inches. So if I'm in the head tilt chin lift position like this, you raise my shoulders off the ground like that, you can leave me. It's not as safe as having somebody with me, but it allows you as rescuers to go on to other survivors and possibly save their lives as well. Does that make sense?
What could we possibly put under his shoulders? What? A sweater, blanket, pillow, clothing, something that's gonna be decently comfortable.
By the way, having the people who are either walking wounded or not wounded at all, giving them something to do not only helps the patient, but remember I said helplessness is the big stressor? Everybody wants to do something. If you can give people something to do, it helps them calm down, gives them something to focus on. So I kind of joke when I teach this class that every disaster should have a pile of boxes that needs to be moved. Right? And I literally have done this. You know, people show up, they want to help, they want to do something, and they're just getting frantic, anxious because they want to do something. We need those boxes moved over there. And then the next day somebody else might come in, you know, 3 other people, they want to help, those boxes need to be moved over there. But giving people something to do can be a great help in helping them stay calm. Aside from the fact that they really can be helpful by keeping somebody's airway open too.
Exactly.
Don't be shy about asking people for help. It's helping them to ask them to help you.
Yeah. Which one of you mentioned stepping on somebody to slow bleeding? Great. Nick. Nick mentions stepping on somebody who is bleeding, well, in place of a tourniquet, I suppose, right? To stop
junctional wounds.
Right, like right here, right?
Yeah, any junctional wound. So junctional meaning it's around the joint. So in here, you can't put a tourniquet on it. You really have to use direct pressure, and especially the femoral artery, the great big one that goes down through your leg here. Person can bleed out really fast, and it takes a tremendous amount of pressure to stop that bleeding. So that's what I was talking about. Actually, standing on it, that's what you have to do.
Yeah, exactly right. And your femoral artery runs. There's a crease right here in your leg, right? Right in the middle of there, that's where your femoral artery is. So you can feel that when you go home, you can feel for a pulse there. That's under a tremendous amount of pressure. I've actually had my femoral artery nicked, and you've held garden hoses where there's a lot of water pressure. You can feel the water pressure vibrating in the hose. That's what it felt like in there. Now the blood wasn't spurt out of me. It pooled up under the skin first, and there was a big bubble there before the blood started to come out. It took 20 minutes of direct pressure to stop that. But, and that was the person putting all of the weight on that wound. But if that had been a larger wound, what Nick said is putting your foot on that wound, or even your knee. You can put your knee on the person's femoral artery right there, and you can slow or stop that bleeding long enough. Hopefully that paramedics arrive with the correct equipment to be able to take over from you. Okay, but a person can bleed up from a big arterial bleed like that, not bleed up, but lose consciousness within about 30 seconds. So, and it goes very, very quickly.
We had a young firefighter named Amy Palmer on his very first fire a few years ago. Cutting down a tree he had no business cutting down. Nobody should have asked him to. It hit another tree, which hit him right here. Gave him a great big wound right here. And just a series of screw-ups, including the firefighters there were putting rags and so forth on here and then pulling them off to look and see if the bleeding had stopped. What they really needed to do was put all that on there, stand on it to stop the bleeding, and Andy would have survived. But
what size tree were they?
It was something that a sea faller should have been dropping. This guy, brand new first fire. He had his chainsaw class SD12, but so many things went wrong in this. So it's called the Dutch Creek incident, and you can watch videos about it and read about it. It completely changed the way we handle medical emergencies on fires, about how we communicate, because it also got communicated badly. So we talked about documentation. We need to communicate really clearly, because the message that the responding medics got from Andy's injury was a broken leg. So they weren't even hurrying. Like, oh, it's broken leg. No, they didn't realize he was bleeding out. And then a lot of confusion about ordering helicopters, and they hoisted him up into the helicopter without putting a paramedic up there first, and he bled out and died. So very famous for no good reasons at all, very bad reasons. It's part of the reason that when I talk about standing on a wound, I talk about getting the wound right here, because, but Andy survived 3 or 4 hours because it took that long with all the confusion about communications, to finally get a helicopter there to hoist them out. So if everything had gone the way it should have, with the wound properly, the bleeding properly controlled, and eliminating all the bad communication, and that's a lot of what changed since it's called the Dutch Creek Protocol, in fact, the way we handled it. He would have survived. There's almost no question, because he survived for a long time despite all that. But he bled out and died in the helicopter. So very meaningful for those of us in wildland fire to talk about how to handle these junctional wounds. Are really, really difficult. Wounds that happen near the junction of the limb and the trunk.
Yeah, those junctional wounds, you put a lot of pressure on them, and it is going to hurt badly when you do that for the person that you're doing that to. Also, tourniquets, you probably mentioned that tourniquets will hurt when you put them on, and then they'll hurt more. And like Nick has said before, they'll be begging you to take that tourniquet off before too long, but you can't take the tourniquet off. Only a doctor can take the tourniquet off because of all the complications that can occur. So, I think we've covered disaster medical operations. When we talk about doing CERT, if you do become a San Jose CERT member, or a CERT member wherever you happen to wind up in the future, you don't have to do medical operations. You can do something else like radio communications, or paperwork, or organizing people, or community education. You don't have this. It's like we say, there's not everybody can do every job, but there's a job for everybody. If you want to be volunteering and learning more, because this training is a start, and then afterwards we have more training to come along. So we have more training. But about for today, so there are questions.
Yeah, I figured it might be tucked in there.
No, that is not the thing.
Oh. Well, you at least got that.
Thank you. Thank you.
I'm sure it's not over there. Oh. Well, you did look over there, I guess, huh?
Yeah, so everyone, you haven't checked your email. My team already said this yesterday. You haven't checked your email, your SJCC email. Dorothy sent an email on Friday, this past Friday. They did decide to go ahead with requiring employees